This high-level event is taking place on the margin of the 39th ordinary session of the Assembly of AU, Head of State and Government. So on behalf of the leadership of these three institutions who are co-convening us this morning, allow me to welcome each and every one of us to Addis Ababa, Ethiopia, diplomatic capital of Africa. Allow me to also invite all of us to the headquarters of Africa's Centers for Disease Control and Prevention. of Africa CDC, Your Excellency, the CEO of AUDA-NEPAD, Your Excellency, the President of Africa Development Bank, Excellencies, Ministers of Health in the room, Your Excellency, Ministers of Finance, Excellencies, former ministers in the room, Excellencies from non-AU countries who are here with us, head of delegations, partners, distinguished colleagues, ladies and gentlemen. On behalf of AUDA-NEPAD, Africa Development Bank, and Africa CDC, who are the co-conveners of this important high-level side event that is taking place on the margin of the 39th ordinary session of the AU Assembly of Head of State and Government. I would like to say good morning and welcome to Africa CDC. Excellencies, ladies and gentlemen, we have a very tight program before us this morning. For the sake of time, I will not go through what we have in stock for you this morning, so we just jump straight into the first item on the agenda. Excellencies, ladies and gentlemen, allow me to invite Her Excellency Dr. Megdis Adaba, the Minister of Health of Ethiopia, to give us our welcome remark. Your Excellency, the podium is yours.
Your Excellency, Dr. Jane Kasai, Africa CDC Director General, Your Excellency, Dr. Nardos Bakala Thomas, Chief Executive Officer of AUDA-NEPAD, His Excellency, Dr. Sidiud, President of the African Development Group, Excellency, Secretary General of the African Continent Free Trade Area, Honorable Ministers, former Ministers, UN agency representatives, development partner representatives in the room, all protocols observed, Excellencies and distinguished ladies and gentlemen. Welcome to Ethiopia, the cradle of humankind and the birthplace of coffee. I'm sure most of us in this room had a coffee in the morning, and we are all energized. Welcome to your second home, to Addis, the capital of Ethiopia. It is a great pleasure and honor to extend a heartfelt welcome to you all on behalf of the government of Ethiopia and in my capacity as the Vice Chair of the African CDC Board. First and most, allow me to extend my sincere appreciation to Africa CDC, the Africa Development Bank Group, the AUDA-NEPAD for convening us in this timely and highly strategic gathering. This event is far more than a meeting. It is a demonstration of leadership in action. At a critical moment in our continent, you have brought together institutions that represent the full spectrum of African transformation agenda. Public health security leadership through Africa CDC, innovative and catalytic financing through the AUDA-NEPAD, through African Development Bank, and delivery of acceleration in the pipeline through the AUDA-NEPAD. Your collaboration reflects a shared commitment to advancing the African health security, the agenda of Lusaka, the African health financing, in the new era of the Green Book. Africa has made significant progress in the strategic policies, the shift we have made so far on regulatory foundation for our health sovereignty, yet, as we all agree, the execution gap still persists. We have all the execution team of critical and significant power in this room. Africa stands in a pivotal moment in advancing its health security and sovereignty agenda. As reaffirmed by the AU Executive Council decision, recognized under the Africa CDC as a continent's public health authority with political, strategic, and technical leadership. However, this mandate is unfolding in a rapidly shifting global landscape, marked by recurrent outbreaks that our continent is facing, evolving geopolitical realities, and increasing unprecedented external support reduction. Thus, dynamics have significantly altered the continent's operational environment and exposes the risk of over-reliance we had over external system. Building on the consolidated continental capacity is therefore not simply an institutional ambition, but also a strategic necessity. Strengthened regional collaboration, sustained investment in country technical capacity, strong governance and structure, greater self-reliance that all of us in this room are aspiring. Most of us as ministers are currently discussing with our heads of state and also with our finance ministers. The health system is central to ensuring that Africa can navigate the future shocks and ready and building on its capacity. Advancing health security and sovereignty in Africa will require stronger and deliberate engagement with regional finance institutions. Development finance institutions, multilateral banks, and national finance entities have critical role in shifting health security from short-term emergency funding towards predictable, long-term investment, but most importantly, strengthen system infrastructure that can absorb and also work on local manufacturing. In this regard, the African Development Bank plays a crucial role by aligning its financial instrument with Africa's development priority, supporting health infrastructure, local pharmaceuticals, vaccine manufacturing, and broader reliance on building initiatives that reinforce our economic stability. Ladies and gentlemen, this is a defining moment for our continent. We all have been talking about it, but this room is going to go out with concrete action. We have before us not just an important discussion, but a historic responsibility to make decisions that will shape Africa's health, security, and sovereignty for the generation to come, not only for our time, but for the generation to come. Our discussion today, if we leave just with statements, is going to be a history, but if we go out with concrete action, it's going to be something that the generation is going to look into us and say, this was shaped before the Agenda 2063 of African Union and our heads of state's commitment to its action. The momentum is real, the commitment is visible, the opportunity is now. We have the African Development Bank stepping forward with strategic financing. We have regional partners ready to coordinate to translate continental ambition and practical action. We have private sectors who are also preparing to innovate, to invest, and to scale. We have also governments demonstrating political will, many stepping up as champions. We have to take the ownership. The alignment of these forces does not happen often, and when it does, it demands decisive action. This is not a time for ideas alone, but it's also for a time for execution. Rather, it's also to move from vision to implementation, to do the actual work that strengthens institutions, building regional capacity, supporting local manufacturing, ensuring that resilience comes with national system strengthening. Let us commit today. Let us discuss. Let us all be on the table today and bring our ideas to shape the future we want for our generation. Here in Addis Ababa, we'll not be revisiting only intentions, but we will be reporting on progress. We'll speak not only about what we plan to do, but what we have delivered. We will be leveraging the available finance, how we can strengthen coordination, and how we can advance Africa's health security and sovereignty with tangible, measurable ways. The responsibility is ours, and the opportunity is ours, and the time for action is now. Once again, welcome to Ethiopia, welcome to your second home, and I wish you a productive and an inspirational engagement. I thank you.
Thank you, Dr. Megdis Daba, co-chair the Africa CDC Governing Board. Excellencies, colleagues, ladies and gentlemen, it is my distinguished honor to invite His Excellency Dr. Jean Kasaya, the Director General and the CEO of Africa CDC, to deliver his remark. DG, the podium is yours.
Wow. a room full of wonderful people. Good morning to all of you. A minister was telling me he's from a Francophone country. He was reminding me that we have more than 55 countries in Africa speaking French. Then he said, I hope you'll speak French today. Then please have your headphones because my speech will be 80% in French, 20% in English. At least we are happy today. Mon équipe a préparé un très bon speech. Mais je me suis inspiré d'une conversation que j'ai eue récemment avec quelques collègues, CEO de certaines compagnies, sur 2 points. Le premier, ils m'ont dit, on ne veut pas investir pour la fabrication des vaccins et médicaments en Afrique puisqu'il n'y a pas de marché et puisqu'il n'y a pas de régulation. I hope the translation is working. If not, I will switch in English. Et un autre a ajouté, les systèmes de santé en Afrique ne vont pas évoluer puisqu'il n'y a pas d'hommes, il n'y a pas d'instruments, il n'y a pas d'argent. I took it as a major challenge. Can we really say that we don't have market in Africa? When we have 1.4 billion people, most of them are young people. Can we really say we don't have regulation in process or in place? Because now we have African Medicine Agency. And we have also our NRAs. But today we are talking about another topic because this topic we'll discuss that tomorrow morning and all of you are invited. President Ruto is organizing tomorrow at 8 a roundtable on local manufacturing. Today we are talking about the second aspect, why our health systems are not moving. Est-ce que c'est vrai que nous manquons les hommes? Combien de PhDs nous n'avons pas dans cette salle? Venant des grandes universités, combien de docteurs, combien de masters? Est-ce que c'est vrai que l'Afrique manque des hommes? Non. On nous dit que nous manquons des instruments. Quels sont les pays qui n'ont pas de documents, qui n'ont pas d'instruments? Presque tous les pays en ont. Et on nous dit que nous manquons l'argent. Est-ce que c'est vrai que nous manquons l'argent? I met a minister when some partners announced that they will cut funding to Africa. He told me, DG, I'm flying to so many European countries, and I will also go to the US and to some Asian countries to look for money. And I asked, how much do you need? Can you just give me one amount of money you need for your health system? He kept quiet. C'est le cas pour beaucoup d'entre nous ici. Demandez à votre voisin ministre, demandez à votre collègue, donnez-moi un seul montant pour le système de santé dans votre pays. We are mostly driven by partners. We are mostly driven by projects. How much do we need for our countries to make sure that our system will be efficient? Ministers will say we have our strategic plan. Yes, I agree with ministers. But if we have this strategic plan, why are we developing different proposals for Gavi, Global Fund, Pandemic Fund, and others? Why are not telling them just, I have my strategic plan, give me money? This one is showing that it's not lack of resources, it's change of mindset. This is why I was meeting President Mahama on Sunday in Accra. We had a very nice discussion on the sovereignty. The agenda of sovereignty is not a slogan. It's a change of mindset. It's just to say, now we know this continent is ours. My country is mine. I have to lead. We have our institutions, FDB, Afrexim Bank, ministers. Who can give me the name of the FDB country director? Who can tell me the last time he met the FDB country director in his country? Who can tell me if he knows how to get money from FDB? Most of us, we know how to get money from Pandemic Fund, from Global Fund, from Gavi. Who knows how much FDB has for the health sector in Africa? I don't want to say it because my brother, Dr. CD, will make it. When we have money in Africa, why we are not using that? I was talking with my brother George Elombi, who will join us from Afrexim Bank. He told me, DG, money is not the issue. What are we talking about? We are talking about mostly inefficiencies. All of you, you will receive, if you didn't receive, you will receive this book, The Financing Africa's Health Security and Sovereignty. It's the main book that President Mahama, the chairperson, and myself used for the op-ed that was out 3 days ago. By addressing inefficiencies in Africa, with the same level of funding that we have, by stopping ghost workers, by improving the integrated planning process, by stopping with inappropriate procurement mechanism, we are saving more than 50% of our health expenditure in Africa. We are on the way to reduce external dependence by around 20% in the next 5 years. Then, if we add to that innovative financing, the Minister of DRC was telling me, I know that he's in the room, we created a new tax. All goods imported in Africa, in DRC, they are giving us 2%. And he told me it's more than $1 billion per year. He told me the government is giving me now 10.5% of the national budget for health. He told me, in addition to that, I have around 7% coming for health staff. That is the country that is achieving Abuja target, in addition to some billions of dollars. What is the issue? Is it money? No. He told me, DG, give me a PFM person, public finance management person, to help me to structure the health system. Ladies and gentlemen, we are recruiting, and today all ministers will receive CVs for the priority countries of the PFM specialist. The problem in Africa is first, address inefficiencies. Second, go to take money where money is. On va aller prendre l'argent chez la BAD. On va aller prendre l'argent chez Afrexim Bank. And third, work in alignment with our partners. I know that Priya is in the room. I know that Sanya is coming tomorrow. I know that Peter Sand, I met him 2 days ago, will send a message. We need to align them under the leadership of the government. Believe me, this is our agenda now in Africa. Fixing inefficiencies, collecting more money from our banks, working for our partners in alignment. If we do that, we'll change the face of Africa. If we do that, the agenda of sovereignty will become a reality. Thank you so much.
Thank you, Your Excellency, Dr. Jean Kesea, DG of Africa CDC, for that great remark. Excellencies, colleagues, ladies and gentlemen, if you are just joining us, this is the AUDA-NEPAD, Africa CDC, Africa Development Bank co-organized side event on deepening collaboration between finance and health leadership to advance Africa's security and sovereignty agenda. At this junction, colleagues, ladies and gentlemen, it is my honor to invite Her Excellency Madam Nardos Bekele Thomas, the CEO of African Union Development Agency. Madam, the podium is yours.
Thank you very much, moderator. Your Excellency, Dr. Magdas Kaba, Chair of the African CDC Board, Your Excellency, Dr. Sidi Ulta, President of the African Development Bank Group, our staunch supporter, actually our backbone, Honorable Ministers of Finance, Planning, Budget, and Health. I forgot my brother, who I should mention first, because if I don't, you know, it's just as if I'm working with half part of my body or my brain. Your Excellency, Dr. Jean Cassier, Director General of the African Center for Disease Control and Prevention. I would also like to salute and greet my sister, Her Excellency, the Executive Director of UNFPA, Madam Jenny Keita. Excellencies, distinguished guests, ladies and gentlemen, all our development partners, philanthropic partners, the private sector that is here, good morning. Good morning. Yeah, I think we need to wake up. It's for me both an honor and a necessity that we meet today for the high-level ministerial dialogue under the banner of advancing Africa's health, security, sovereignty, and sustainability. The conversation, ladies and gentlemen, on Africa's health systems is undergoing a steady but profound shift. For decades, we have spoken about Africa's health systems primarily through the lens of expenditure, consumption, treating the health of our citizens and its economic implications as a social cost to be contained, and how much governments, by saying how much governments must spend, how much partners could support, and how wide the financing gap remained. That was always the conversation. But today, a different reality is emerging. In this reality, we are beginning to see health not only as our collective budgetary obligation, but as one of Africa's most consequential economic frontiers. Across this continent, demographic expansion, urbanization, technological adoption, and rising domestic demand are converging to shape a rapidly expanding global health economy. And you rightly said it, my brother Jean. One in which Africa must participate not at the margins, but at the forefront. As a producer, an innovator, and an investment destination, with the policy and financing sovereignty to set our priorities and secure our economic transformation. Excellencies, honorable ministers, in each of our governments, the national budget is ultimately a statement of national priorities. And across Africa, governments are making consequential financing choices, investing in infrastructure, strengthening industrial capacity, and expanding the foundations for long-term growth. Yet, ladies and gentlemen, the investments that most directly determine the productivity of our workforce, the resilience of our economies, and the stability of our societies are still too often categorized as consumptive expenditure rather than economic strategy. And when we place this against the projected 81 billion debt service bill for Africa and an estimated 12 billion health financing shortfall following the unprecedented funding cuts of 2025, Africa's health sovereignty can no longer be a slogan. It must become our financing strategy. Excellencies, Africa already spends, you know it very well over $100 billion on health, about $119 billion in 2020, with roughly 48% coming from private sources, 42% public, and 10% external. This is not marginal spending, we know. It is the early formation of one of the continent's most important economic markets. Our task, like our DG said, is to structure it, to reduce catastrophic out-of-pocket burden and crowd in blended forms of complementary capital into priority health value chains for better health outcomes. And so, one truth is clear. Africa should and will spend on health. The question we have to ask ourselves is whether that spending will be structured toward sustainability, unlock system efficiencies, crowd in blended investment, and generate lasting economic value. Distinguished guests, today's dialogue is about how we accelerate together that shift, deliberately, collaboratively, and institutionally, at scale. Under the championship of His Excellency Paul Kagame, through the Africa Leadership Meeting Declaration, African leaders reaffirmed a critical truth. Sustainable health financing cannot rely solely on incremental adjustments. It requires structural reform and the deliberate mobilization of blended and diverse investment to complement public resources, reduce reliance on external financing, and scale domestic manufacturing and service delivery, grounded in stronger efficiency measures and disciplined stewardship of public funds. With the support of our AU institution, the African Union Development Agency has undertaken since 2019 by translating the ALM declarations, which I just mentioned, into implementation through the operationalization of the regional health financing hubs and the advancement of structured private sector engagement. And this we do together as one, and delivering as one with CDC, AFCFTA, and the AUC. To date, encouraging progress is already visible. Across the 4 operational regional health financing hubs in East African Community, South African Development Community, West African Health Organization, and Intergovernmental Authority on Development. We are translating continental commitments into country reforms. In 2025 alone, more than $8 million was mobilized to strengthen the hub's capacity, analytical functions, and member states' engagements with the Economic Community of Central African States and the Arab Maghreb Union onboarded, and expanding this continental architecture into Central Africa and North Africa. We're also seeing domestic resource mobilization move from aspiration to action. Following national health financing dialogue processes and sustained engagement through the hubs, Malawi, I'm proud to announce, doubled its health sector budget in 2024, and Zambia increased its health budget by 20%. At the same time, a growing wave of earmarked syntax, which Jean just said, syntax proposal is taking root across Kenya, Rwanda, Tanzania, Zimbabwe, and Namibia to create more predictable domestic streams for health. And I would add DRC now. And public financial management reforms are advancing through measurable instruments. Countries are increasingly pivoting to PFM reform as the most viable pathway under constrained fiscal space, including Malawi's World Bank Program for Results model, which ties financing to results and outcomes. Importantly, a pipeline of system reforms is emerging, including Mozambique's digitized e-procurement platforms, Namibia's transition to program-based budgeting, and Zambia's parliamentary commitments to strengthen PFM and procurement legislation, among many others. And through the 11 national health financing dialogues undertaken to date, we see ministries of finance and ministries of health coordinating more deliberately than ever before, because the stakes are now undeniable. When out-of-pocket spending reaches 2/3 of total health expenditure, households become the de facto health financiers, and health sovereignty collapses. And embedded within regional economic communities, the regional health financing hubs are also strengthening expenditure efficiency, advancing financing strategies, and sustaining the policy dialogue required to crowd in investment. In the spirit of Africa Team, these regional platforms are helping translate ambition into fiscal reality. But we must go further, because reform alone is insufficient without a long-term pipeline. And innovative and blended forms of financing do not follow intentions. They follow well-structured, investment-ready opportunities. Building on the lessons from implementing the African Leadership Meeting agenda, an emerging request became clear: the development of a comprehensive mechanism under the ALM Continental Framework to attract investment into Africa's health sector. Excellencies, it is this understanding that led also the AUDA-NEPAD to complement the Green Book that Dr. Jean Cassia was talking about, a most important document. To establish, we have also established a program for investment and financing in Africa's health sector, the PIFA. This is not just another additional thing, it's a complementary thing to what the CDC had produced. And it's really a very comprehensive one. And all this is really to make sure that our health financing demands are really coordinated and that we work together. And I'm so glad that we at the African Union, the three organs, which is the CDC, ourselves, and the FCFTA, are working together to make sure that we meet the demands of, the health system in Africa. And today, we are proud to signal a major milestone on that journey. Through our FIFA project list, Africa's Health Market Atlas, we have already identified over 250 priority health market projects across the value chain: local manufacturing, infrastructure and diagnostics, service delivery, digital systems, workforce development, and research and innovation ecosystems. This first continental pipeline is more than a catalog. It's a blueprint to identify, structure, and accelerate health investment projects across Africa. Several of these projects are being spotlighted here today through our snapshot publication, and the full compendium will soon be accessible through the PIFA digital portal as we move toward its launch. Distinguished guests, in a global environment of tightening fiscal space and an evolving development finance landscape, Africa certainly must increasingly finance its own transformation, while strategically crowding in investment. So we are supporting this shift by positioning health not only as a social imperative, but as a growth sector, capable of delivering measurable social impact, strengthening economic output, contributing to the fiscus, and advancing the sovereignty and sustainability of Africa's health systems. For member states, the call is clear: deepen policy coherence, strengthen public financial management and stewardship, invest in project preparation, and leverage the platforms for financing to bring forward priority health investments aligned with national development plans and capable of attracting blended and private capital. Ultimately, the strength of this marketplace will be determined by the quality of the opportunities that countries put forward. For development partners and philanthropic institutions, this moment presents a catalytic opportunity to support the PFM reforms that anchor sustainability, to de-risk early project preparation, and to help capitalize platforms that enable blended financing and private investment to flow at scale. The question before us is no longer whether transforming Africa's health economy is necessary, but whether we will finance it with the urgency and strategic discipline it demands. With clearer standards and more predictable demand signals, Africa's health economy is transforming, anchored in African priorities, open to strategic partnerships, and increasingly organized into investable pipelines. We stand ready to work with member states, our continental institutions, and partners to institutionalize this transition, because health sovereignty is not declared, it is financed, it is governed, and it is sustained. I thank you very much.
Thank you, Your Excellency, Madam Nardos Bekele Thomas, for that great remark. Excellencies, distinguished colleagues, ladies and gentlemen, it is my honor to invite His Excellency Dr. Sidi Ulta, President, Africa Development Bank Group, to deliver his remark.
Honorable Ministers of Finance, Budget, Planning and Health, His Excellency Mekdes Kaba, Minister of Health of Ethiopia and Chairperson of the CDC, my dear brother Jean Kaseya, Africa CDC DG, my sister Nardos Bekele Thomas, CEO AUDA-NEPAD, my sister, Excellency Diana Keita, Executive Director of UNFPA, distinguished guests, ladies and gentlemen. The African Development Bank Group is honored to join forces with Africa CDC and AUDA-NEPAD to initiate a strong and efficient partnership between finance and health. Indeed, to safeguard the long-term prosperity and stability of the continent, it is essential for us to transition from the palliative measures that have historically characterized our healthcare ecosystem towards the adoption of the new African financial architecture. This architecture represents a seismic shift toward financial self-determination by re-engineering how we mobilize, manage, and deploy resources. We are ensuring that Africa's health is no longer a matter of global charity, but of continental sovereignty. The new African financial architecture will drive the transformation under a fourfold path anchored in the bank's 4 cardinal points, which serves as a compass for our new era of finance and health sovereignty. The first cardinal point is about unlocking Africa's capital power. We are moving beyond the limitation of traditional debt. Through the new African financial architecture, the banks seeks to deploy innovative financial instruments and risk mitigation strategies to crowd in the private sector and philanthropies. By treating health as a productive asset rather than a social cost, we can mobilize the billions required to bridge our funding gap and reduce out-of-pocket expenditure for our citizens. The second cardinal point is about rebuilding Africa's financial sovereignty. The fundamental mission of the new African financial architecture is to harmonize our diverse regional institutions into a synergetic and responsive framework, ensuring collective resilience. And I am really pleased to see that my brother Serge Ekwe, the president of the West African Development Bank, who is an active defensor of NAFA, is here with us today. Welcome. We are re-engineering our system for global agency, ensuring that Africa has the institutional strength to manage its own risks. A sovereign continent cannot depend on the fluctuation of external aid for its vaccines. We must finance our health through domestic resource mobilization and African-led financial institutions. The third cardinal point is about how to turn our demographic into a dividend. Africa's youth and women are our greatest resource, but only if they are healthy and productive. Through NAFA, the new African financial architecture, we plan to scale local production. By localizing the value chain for medical products, we create jobs for our youth, empower our medium and small enterprises, and ensure that our growing population is an engine of economic growth. And in this regard, I am pleased to announce that we are working with UNFPA to launch a program which will support this third cardinal point. The fourth cardinal point is about building resilient infrastructure and adding value to our natural resources in Africa. Our strategy for quality health infrastructure centers on building resilient facilities that optimize resources through strategic private sector partnership. By integrating renewable energy and regional value chains, we strengthen the multilateral cooperation essential for a sovereign African-led response. Quality infrastructure remains the indispensable foundation of our continental health security. Excellences, Mesdames et Messieurs, cette approche des 4 points cardinaux établit le cadre d'un pacte entre la finance et la santé. Pacte qui est conçu pour redéfinir le paysage stratégique de notre continent. En alignant la politique budgétaire sur la sécurité sanitaire, nous passons de la vulnérabilité à la résilience. Et nous concrétisons les aspirations de l'agenda 2063 pour que nos systèmes puissent résister au choc de demain. Cette approche nous permet de passer de la fragmentation à l'intégration, tirant parti de la nouvelle architecture financière africaine pour unifier nos ressources dans le cadre d'une vision continentale collective. La nouvelle architecture financière africaine, NAFA, nous offre une occasion historique d'aligner notre vision commune en favorisant une synergie plus étroite entre les ministères des Finances et les ministères de la Santé. Nous proposons un pacte finance-santé tourné vers l'avenir afin d'intégrer les priorités en matière de santé dans nos cadres macroéconomiques. Nous le ferons en ayant recours au financement mixte pour que chaque ressource serve d'investissement à haut rendement au service de nos populations et pour l'avenir de notre continent. Excellences, Mesdames et Messieurs, le groupe de la Banque africaine de développement est prêt à faire équipe avec vous pour renforcer l'efficacité budgétaire, catalyser les financements mixtes et garantir des retombées économiques mesurables pour chaque ressource engagée. Permettez-moi maintenant de vous souhaiter des délibérations productives et instructives. Nous attendons avec impatience les résultats concrets de cette session, comme l'a dit Madame la ministre de la Santé de l'Éthiopie. Puissent nos efforts collectifs au cours de ces travaux poser les bases d'une Afrique transformée, une Afrique saine dans ses fondements, une Afrique résiliente sur le plan économique et pleinement souveraine dans son avenir. Je vous remercie.
Thank you, Your Excellency, Dr. C.D. Ulster, for that great presentation. Excellencies, colleagues, ladies and gentlemen, it's time for us to take us through an overview of health financing for health security and sovereignty on the continent of Africa. This is a joint presentation by Africa Development Bank, AUDA-NEPAD, and Africa CDC. So to take us through this presentation will be Dr. Ngashi Ngongo, Principal Advisor to the Director General of Africa CDC. Ngashi?
Pointer or something that can be used to. Yeah. Excellencies, distinguished guests, ladies and gentlemen, I'm going to make this presentation on behalf of Africa CDC, AUDA-NEPAD, and FDB, just to share some information for setting the scene on the panel discussions that will follow. During this presentation, I just want to share a few slides on the macro fiscal environment of Africa and also discuss few implications on health financing. Next. Now, during this, I think I'm going to cover 5 points. First is why this discussion becomes important now. And secondly, to present Africa's macro-fiscal space realities of today. I then touch on the health financing. I talk about the composition and the trends that we've seen over the recent years. I talk about the issue of efficiency that His Excellency, the Director General of Africa CDC emphasized this morning in his remarks, and then I'll end up with the way forward. Just to start, why is this discussion so important now? Many of us in the room are seeing and are witnesses that Africa is facing really tight fiscal environment, while at the same time, the challenges that we are facing also, especially in the health sector, increase the needs of the continent. We have seen multiple overlapping crises striking us, health emergencies. Since 2020, we went through the COVID-19 pandemic. Since 2024, we've been talking about mpox, but at the same time, we've also seen even the countries affected by mpox also go through Ebola, Marburg, cholera, and many other outbreaks that are happening at the same time. All of them putting pressure on the fiscal space. The climate change-related disasters also, we have conflicts that are going on, we have economic shocks, all these needing resources for us to be able to respond. But at the same time, we've also seen that the debt servicing has been increasing also in recent years, taking even the money that we could use actually to address some of these challenges. And since last year, I think we've been talking about the global financing crisis with the declining in ODA. But as you know, it is often said that it is in moments of crisis that innovations are born. I think that's the reason why we are gathered here, is to think through some innovative solutions that will help us navigate these challenges. Now, of those areas that innovations are required, I think just thinking about what are the budget choices that countries should be making now. We are just looking at these 2 options with some of the evidence that has been documented on each of them. One is that we could consider then reducing or making cuts on the health budget as a way of saving money. But we know that there's enough evidence to show that when we do that, the implications are that we'll be weakening our health systems even further, with the implication that we will see the rise in the burden of disease, and we also see the rise in outbreaks that are happening. But then in the long term, what we expect on the fiscal and economic environment is that we see higher emergency spending because we'll be requesting for supplementary budget and borrowing. We'll see an increased cost of treatment because the burden of disease is increasing. And all that will lead to the loss in productivity. As we know, the work that the studies conducted by WHO and the World Bank show that that could lead to the loss of trillions of dollars in economic output. But the opposite of that, they can also make courageous decisions to invest more in strengthening the health system in these difficult times. And in the long term, in the long run, what we expected to see more predictable expenditure, stronger workforce, and with the stronger workforce, then increased productivity and expanded task base, because we have healthy populations that are at work that can contribute to our taxes. There's enough evidence, just to touch on these 2, that when you invest in nutrition, for example, improvement in childhood nutrition can raise adult wages up to 50%. That is considerable, very significant. Similarly, also with immunization, that $1 invested in childhood vaccination can bring returns on investment up to $54 in economic benefit. I think those are the things that are very well documented that we could consider as we are reflecting on those transformative decisions and strategies we need to adopt now. Now, when we look at the growth of our economies on the continent, we've seen that in recent years, we've seen a really steady increase in economic growth. But when you look at the overall GDP of the continent, in 2025, it was estimated at about $3 trillion for the entire Africa. And that is for a population of 1.4 billion. But when we look at the GDP of Germany alone, a country of 89 million, the annual GDP the same year, 2025, was estimated at 5 trillion. And then you take California, which is just one state in the United States, with a population of 39 million, they had a GDP of 4 trillion. That already tells you that we have work to do also in terms of innovating, how we can generate more resources, more revenues that could benefit our social services. But the most important message here is that we have seen our economic growth, which is very encouraging, but it's not enough to be able to take care of our social needs in health included. That's why they expected now, I think some of the work that has been done, that Africa should reach an economic growth of about 7% to be able to provide for the social services that are important to our populations. Now, we spoke about the debt service. If we look at what has happened over the last 15 years, between 2009 and 2024, we'll see that expenditures on health and education as a proportion of the national budget have remained stagnant over the last 15 years. But at the same time, we have seen that the debt servicing has increased more than 3 times, from about 5% in 2009 to close to 16, 17% in 2024. That is what is happening at the same time. And then that situation, as we all agree, cannot continue like that. I think we need to rethink again the debt, especially to consider some of the discussion on the debt swap that is important to be able to generate more money that can go into our social services. Next. Also, looking at the health financing, that's the composition of it. I think a very important message that comes out of here is that overall, more than 3/4 of health expenditures come from domestic resources, I think, which is something very important. But what is worrisome is that when we look at domestic resources now, close to half of that comes out of pocket. I think that's what was mentioned. I think when the CEO of AUDA-NEPAD was talking about, pushing population into poverty, it's exactly why we have the risk on the continent. And also something else that we have seen some decline in out-of-pocket, I think, over the last 15 years. But if you look at the graph, it is that also coincided with the increase in the ODA. Now that the ODA is going down, there's a risk to see the reversal of that trend now, meaning that if government does not increase its contribution, it will be more, again, the population that will take care of the financing gap, again, going in the opposite direction of what everyone would like to see. Now, looking at the external aid itself, I think there are important observations that we needed to mention here. 4 key trends that have characterized the global aid architecture in the past 20 years. One is the issue of the proliferation. I think you've seen the number of donors double. With that also, we've seen also the doubling of the number of donor implementing partners. That means that has increased actually the transaction cost for the government having to deal with so many implementing partners that are all coming. And then the second issue is that that has also led to the fragmentation, because the size of the grant has decreased because there are more implementing partners that have to share the ODA that is available, again, putting more pressure on the government to deal with so many partners bringing much smaller grants instead of having fewer partners but with bigger grants to manage. Another very important development is the verticalization. I think we've all seen the verticalization of external aid. Instead of strengthening the health systems on its entirety, it has focused on certain diseases. I think we've seen all those experiences of malaria, HIV, instead of strengthening the entire health system to be able to deliver a package of services that can optimize the impact on the health outcome. But the most important that we wanted to highlight here is the circumvention, meaning that the proportion of that ODA that goes to government during the same period has been going down. You know, has moved from 36% of ODA around 2006, 2008 to just about 20%. That means that 80% of the ODA now does not go through the government system. That's why Minister of Health might even not know that there is funding that is supposed to be supporting national priorities. Now, on the infrastructure development, I think that's also another area that has seen so much weaknesses that over the last 15 years, when you see, we have seen an overall decrease in investment in infrastructure. Although it has remained below 8% in general, but it was around 7% in 2010, but now it is around 5% in 2025. I think just to say that this is an area that requires really, again, rethinking on how countries can invest in this area. There have been some work done to estimate the needs. They are around 25 billion, but it's just about 4.5 billion that is invested, representing about 20% of the needs, which is an important area. And I'll come to that, linking to the comment that DG just made during his welcome remarks. Now, the issue of efficiency is one that is extremely important. You know, if you look at this graph, we compared the life expectancy on the left with the GNI, you know, just to see the correlation between the two. Overall, what we see is that there is a positive trend when we see that dotted line, green line that is going up. You know, we see there's a correlation between the level of the GNI and the life expectancy, which is expected trend. But the important observation is the fact that the green are the low-income countries, the yellow are the low-middle-income countries, and then the red are the upper-middle-income countries. If you look at the green, you notice that there are some of the greens that achieve better life expectancy with much lower GNI. That means that there is more efficiency in those countries than in the countries that achieve similar or less with 4 times or 5 times the GNI of those countries. I think that's because, you know, on one side, there's the issue of looking at the actions where the investment have gone. Most importantly is to ensure that those actions also target the social determinant of health that are extremely important to invest. And secondly is the issue of efficiencies, both in the allocation but also in the production that we mentioned before. Now, inefficiencies are really striking in the African health systems. I think there's work that was conducted by WHO that showed that 20 to 40% of resources that are spent are wasted because of inefficiencies. But when you look on the government side, most of those resources that government invests go to human resources and also to medicines. I think almost 80% of the budget goes there. But we know the issues of inefficiencies when it comes to the human resources, both human resources and medicines. Human resources is the problem of the poor skills. We have the problem of the maldistribution of human resources. We have the problems of even services that do not match the skills, of the human resources where they are affected. That all lead to inefficiencies. On the procurement is the issue of procurement processes that usually do not prioritize value for money, with the corruption and everything that goes on, that also again highlights the importance in that sector. On the private sector, what happens that we still see the predominance of out-of-pocket, as we said, almost 50% of domestic resources that that go into health expenditures come from out-of-pocket. But the implication of that is that you see that that leads to higher prices, of services, sometimes unnecessary services, just to get more money from the people that are paying. In some cases, even delayed care, because people really, they can't afford the service, they take more time. And delayed care means also advancement of the conditions and really care that becomes much more costly, because if they came much earlier in the process, they could have benefited from much simpler interventions. And finally, on the donor side, as we said, inefficiencies has also been documented because of the verticalization, that instead of investing in the system, they invest in specific programs, and also the lack of alignment with the national priorities. That makes that some of the investment did not actually target the priority that will have the greatest impact on the return on investment. But they have to say that it's true that we can see all those weaknesses, but at the same time, we also need to look at opportunities, because that's what we are here for, is to see the solutions to the challenges that we are facing. One is that there's clear evidence that the digitalization could be a very important fiscal efficiency multiplier. It acts on everything, whether in the management of financing, in the management of procurement, in the delivery of medicines, the telemedicine. I think it is one very important factor that can really help our effort to improve efficiencies in the system. Secondly, is the regional approach is also extremely important, as we are trying also to create the economies of scale, that especially when we talk about local manufacturing and the procurement of medicines. That buying alone, the volumes are small, but buying together, the volumes are huge. We are in a better position to negotiate the pricing, which means that it is also one very important strategy that need to be considered as we talk about efficiencies. And finally is local manufacturing, which is clearly one emerging core health market driver. That local manufacturing not only is important for the health sovereignty that Africa is pushing now, it's also important to boost the economies of countries, because it will create jobs that will also contribute to the social determinant of health again, and the reverse back into the improvement of the health outcomes in the country. Next. Now, to finish, I think when you look at that situation, the micro-fiscal space and some of the implications on the health financing on the continent, which is the purpose of this meeting, is that it is clear that it's extremely important to strengthen the collaboration between health and finance, to be able to address all those challenges around efficiency, around innovation in financing, and also, very importantly, the issue of strengthening the public health, public finance management that we had already, the previous speakers mentioned. Secondly, I think DG highlighted this point so clearly, that we have already opportunities on the continent that we need to leverage. Let's first use what is in our hands. For example, Africa CDC is deploying about 20 PFM experts in the countries to help our member states improve public finance management. I think that is a resource that is in our hand. Secondly, we have the platform for harmonized African health product manufacturing, the FAM, that we all need to support to make sure that it works for us, it works for our continent, that we can produce our own medicines locally on the continent. Thirdly, we have the decision of our head of state also that gave us the establishment of the African pooled procurement mechanism. If we do not support that mechanism as the collective, all of us coming together, it is not going to work. But it is to our advantage, as we talk about efficiency, that we buy together and we buy volumes to negotiate pricing. The African Development Bank, I think that's what DG mentioned this morning, has two initiatives that bring together $6 billion available to strengthen our health infrastructure, but also support the manufacturing of medicines, vaccines, and therapeutics. I think that's an instrument. It is there available to us. We haven't optimally used it. I think this is now really the opportunity for us to see how we can make better use of that. AUDA-NEPAD has got the PIFA initiative that support the member states to really translate this commitment into the financing reforms. I think it is an initiative that is there. It is for us. I think we also need to see how we can make use of it. And then finally, we have the ALM, Regional Health Financing Hubs, I think that are also there to support our effort on sustainable financing reform. Now, the second thing that we also need to look on the private sector, how we can better engage the private sector, how we can harmonize the frameworks that we have there for public-private partnership to take advantage of their investment in health. And also, I think it was mentioned before that this is really the time to have a public health agenda that is country-led. Country-led around one plan, one budget, one M&E framework, all the partners coming to align behind national priorities that are led by the government themselves. I think we have the recommendation of the Lusaka agenda. Now, with everything that is going on right now, it is the right time for us to operationalize that commitment. And finally, is that we also need to strengthen the accountability and impact that are extremely important. Reason why we need to also work on establishing shared data and M&E platform that can allow that transparency. I think that is the summary of what we wanted to share. On behalf of my colleagues, excellencies, distinguished guests, ladies and gentlemen, I would like to thank you for your attention. Thank you.
Thank you so much, Ngashi, for that presentation. And that brings us to the end of the first part of this high-level side event. So we'll be breaking for 5 minutes just for our family photo. Now, when we return, we're going to have 4 different panel sessions. The first one we center around the ministers of health from upper and middle income countries to reflect on health financing. That will be followed by another panel discussion for low-income countries. Then we'll move straight to the panel discussion for our finance ministers in the room. This will be followed closely by a panel discussion for our donors to also share their reflection as far as health and finance collaboration is concerned. And the last panel discussion will be for our partners to also weigh in as far as this agenda is concerned. A very short announcement from Ethiopia. We are invited to visit the National Artificial Intelligence Center. Our ushers will guide us. The ushers have been attached to each and every minister. The second invitation is still from Ethiopia. We are invited to visit the Ethiopia Public Health Emergency Operations Center, state-of-the-art facility here in Ethiopia. Again, our ushers will guide us. Your Excellencies, colleagues, ladies and gentlemen, so it's time for us to go out just for 5 minutes and take the family photo. Protocol will guide us to where we have this family photo. Thank you. can we take our seat?
Okay.
Dr. Guy Patrick Obiang. So, Excellencies, we are about to start the first panel discussion. Please join me to welcome on stage the moderator for the first panel, in person of Dr. Patrick Guy Obiang, former Minister of Health of Gabon.
You confirm who is calling?
Excellencies, can we take our seat? I don't know your notes. I don't speak very good French.
Yeah. Okay, no problem.
So these are the countries: Morocco,
Okay.
Zimbabwe,
Morocco.
All right, so Your Excellencies, we are about to start the first, panel discussion. And it's my honor to introduce the moderator for the first panel, in person of Dr. Guy Patrick Obiang, the former Minister of Health of Gabon. And to join Dr. Patrick Obiang in this particular panel are the following ministers from Morocco, Zimbabwe, Kenya, Ghana, South Africa, and Tunisia.
Fine. Okay. Zimbabwe, Morocco, Tunisia, okay. South Africa, Ghana. Distingués invités, mesdames et messieurs, bonjour. Je suis docteur Guy-Patrick Aubian, ancien ministre de la Santé. J'ai l'honneur de présider le premier panel table ronde des ministres de la Santé, qui est une table ronde de haut niveau au cours de laquelle les différents ministres de la Santé ici présents nous présenteront les expériences partagées en matière de gestion, en matière de gouvernance de leur système de santé. Comme vous le savez, les ministres de la Santé ont cette grande responsabilité de pouvoir mettre en œuvre les politiques publiques au sein de leur département ministériel. Dans l'exercice quotidien, ils élaborent des plans de développement sanitaire, ils élaborent des plans d'action, ils les budgétisent. Mais régulièrement, ils sont confrontés à une mobilisation des ressources financières, mobilisation de ressources financières internes, mais aussi mobilisation de ressources financières externes avec des bailleurs. Ce d'autant plus qu'actuellement, nous avons des contingences économiques, notamment une crise économique mondiale, mais aussi les pays, plusieurs pays africains sont très endettés. Et donc, au cours de ce panel où nous échangerons avec les différents ministres, ils nous partageront leurs différentes expériences, mais aussi ce panel prépare le panel suivant qui est la rencontre avec la discussion avec les ministres des Finances pour que les ministres de la Santé puissent nous dire les relations qui existent entre eux et les ministres de Finances pour sécuriser les budgets qui leur sont alloués, les rapports qui existent entre les ministres de la Santé, mais aussi les partenaires au développement pour pouvoir faire des appuis budgétaires, mais aussi quelles sont les innovations qui leur permettent de mobiliser des ressources financières pour pouvoir atteindre les objectifs qui leur sont assignés. Donc, à titre de rappel, nous avons ici présent le ministre de la Santé du Maroc, du Zimbabwe, du Kenya et du Ghana. Sans plus tarder, nous allons commencer avec le ministre du Kenya. Est-il présent? Le ministre du Kenya. OK. Nous allons donc commencer avec le ministre du Ghana. Alors, monsieur le ministre, translation, please.
Hello?
OK. It's OK? C'est bon? OK. Monsieur le ministre du Ghana. Monsieur le ministre, votre pays fait face à des pressions budgétaires, à des contraintes budgétaires liées effectivement à l'aide. Il y a un problème de traduction. Translation, please.
Hello? Hold on, let me see. You should speak and let me hear you. I can't hear anything for now.
OK. C'est bon, vous m'entendez?
Yeah, but I lost out completely in your introductory remarks, so if you can repeat that again.
OK. Alors, nous allons poursuivre cet échange. Donc, Monsieur le ministre, do you understand?
System is not working. Happening. Use it yourself and see. You take it and use it. Okay, when it comes to give it to me.
You say something?
English? Yes, English. English is what? English is what channel? Two. Now let me hear you if I can hear from
OK, merci. Je pense que j'aurai le même problème avec mon casque. Alors, Monsieur le ministre, votre pays, le Ghana, vous êtes ministre de la Santé et le gouvernement vous assigne un certain nombre d'objectifs pour pouvoir améliorer la santé des populations. Alors, nous voulons savoir quelles sont les contraintes budgétaires auxquelles vous faites face par rapport à la mobilisation des ressources internes, mais aussi compte tenu de l'aide au développement qui de plus en plus diminue.
It's working.
Comment
English.
arrivez-vous
Good. It's already on one. Please let me hear you.
OK. Bonjour, Monsieur le ministre. OK. En tant que ministre de la Santé du Ghana, votre gouvernement vous fixe des objectifs visant à lutter contre la maladie et à tendre vers l'accès universel aux soins. Vous êtes certainement confronté, comme plusieurs pays, aux contraintes budgétaires. Comment faites-vous pour pouvoir atteindre ces objectifs dans un contexte financier difficile? Quelles sont les relations que vous entretenez avec le ministère des Finances pour pouvoir sécuriser votre budget, le budget qui vous est alloué, sachant parfois qu'il y a un décalage entre les écritures budgétaires et la mise à disponibilité de ces fonds? Aujourd'hui, l'aide au développement est en train de diminuer. Comment faites-vous pour pouvoir atteindre les objectifs qui vous sont assignés par le gouvernement? Vous pouvez répondre.
Good. Thank you very much for the opportunity. A lot is happening at this moment in Ghana with respect to the health sector. As we all know, there's a complete decline in the donor funding, but we have put certain systems in place. For example, in Ghana, we have what we call the National Health Insurance Authority that has been established, and a levy has been imposed on the people of Ghana. And so this is a very reliable sources of funding for the health sector in Ghana. And that system has gone through a lot of, processes, from the pilot stage to the mutual health insurance, to the national health insurance, to the capping and to the uncapping. And so at this point in time, what His Excellency the President has done is that we have done what we call the uncapping of the National Health Insurance Fund. Before then, a certain percentage of the National Health Insurance Fund used to go into a fund we call the Consolidated Fund. But due to the dwindling of the donor funds, the President has uncapped the National Health Insurance Fund. So any levy that comes in the name of the National Health Insurance Levy is now being expended in the health sector. And so, for example, after the uncapping, we were able to free about $350 million additional money into the health sector. And so we are investing this money where it is needed most. So, for example, the non-communicable disease aspect in Ghana is killing people at a very alarming rate. And so part of that funding has been dedicated towards the treatment, the funding of the treatment of non-communicable diseases. And so it's a reliable money. And again, because it is a levy and it is reliable, part is also going to be rolled out to what we call the free primary health care. And because everybody in Ghana is paying the national health insurance levy, the president believes that every Ghanaian must benefit the basic, one, which is the primary health care. And so we free that money, and we are in the process of rolling out the free primary health care. And so in as much as we are having, decline in the donor funding, His Excellency the President, at every point in time, is giving direction, whether it is the financial scheme that is increasing allocation to the funding, or the main budget is also increasing allocation to the funding. And in Ghana, we see the health sector as an investment and not necessarily, an expenditure on the budget. And so at every point in time, our releases into the health sector is prompt. So they release the money timely so that we achieve what we have set for ourselves in the sector. And I'm collaborating very well with the minister responsible for finance. So in every month, I engage the minister responsible for finance, and we speak. Then he gets to know that, look, in this quarter, this is what we are releasing, and we have something we call commitment authorization. So whatever projects we need to do in the health sector, he issues the commitment authorization, it goes through the processes, it is released timeously, and we'll monitor to make sure that that has been implemented. And there are a lot of processes. For example, I made mention of the National Health Insurance Fund. The National Health Insurance Fund, for example, before the allocation, the details of the allocation is done, it must also go back to Parliament for Parliament to approve the formula. And so Parliament determines what that money must be used for, again, apart from the main budget. And so we are collaborating very well with the minister responsible for finance. And because our funds are also statutory, it is very difficult to touch it without using it for its intended purpose. Yeah.
Merci, Monsieur le Ministre. Nous notons qu'il y a une bonne collaboration entre le ministère de la Santé et le ministère des Finances, mais également que vous bénéficiez des appuis institutionnels pour pouvoir atteindre vos objectifs. Nous allons donner la parole au ministre du Maroc et dire aujourd'hui que nous sommes effectivement confrontés à cette problématique de financement du système de santé. Et qu'est-ce que vous pensez qu'on peut faire en termes de renforcement significatif entre la collaboration des ministères de la Santé et des Finances? Je le dis parce que moi-même, de ma petite expérience, j'ai été ministre de la Santé. Il y a des chiffres annoncés, mais également des chiffres mis à disposition. Il y a également un système de doublon entre les financements internes, mais les financements extérieurs, avec des partenaires au développement, comme ils l'ont si bien signalé tout à l'heure. Comment faites-vous pour pouvoir assurer une gestion transparente de tous ces fonds et accroître le financement national et d'améliorer l'efficience de vos actions?
Tout d'abord, je voudrais vous remercier pour l'invitation et la participation à ce panel de haut niveau dans un contexte qui est le contexte africain d'investissement massif dans le secteur de la santé. Alors, évidemment, la discussion entre ministère de la Santé et ministère des Finances est toujours une discussion un peu ardue dans laquelle on est engagé à négocier des enveloppes budgétaires dans une optique de couvrir des coûts. Mais je pense qu'avant de discuter financement, il faut d'abord discuter investissement. L'investissement dans le secteur de la santé, il est aujourd'hui primordial, il est nécessaire. Et avant de se poser la question du coût de l'investissement, on devrait également se poser la question du coût du non-investissement dans le secteur de la santé, qui peut avoir des répercussions, qui a des répercussions très importantes sur la croissance économique. Une population qui n'est pas correctement prise en charge au niveau de la santé ne participe pas à la croissance économique, ne participe pas au développement des sociétés. Et pire encore, le coût des crises, le coût de prise en charge des crises sanitaires peut également être très contraignant pour les finances publiques, pour l'endettement des pays. Et c'est donc ce non-investissement dans le secteur de la santé qui a des répercussions négatives, qui nécessitent de revoir complètement la logique d'investissement. Aujourd'hui, au Maroc, nous avons pris le pari d'élargir la couverture sociale, la protection sociale, la couverture médicale, en mettant en place un système qui est drivé au plus haut niveau par Sa Majesté le roi Mohamed VI, qui a mis en place un système qui est accessible à l'ensemble des Marocains. En l'espace de quelques années, depuis 2022, nous avons intégré 22 millions de personnes, 22 millions de citoyennes et de citoyens dans le système de protection sociale, donc qui ont désormais accès à la couverture médicale et qui vont bénéficier de cette couverture médicale pour pouvoir être pris en charge au niveau du coût sanitaire. En faisant ça, nous avons également lancé donc un investissement massif dans le secteur de la santé au niveau de l'infrastructure pour améliorer notre infrastructure, la remettre à niveau, chercher l'équité territoriale pour régler le problème des déserts sanitaires. Nous avons beaucoup investi également dans la formation des médecins, dans la revue du système de formation des universités. C'est un sujet qui est également dont tous les pays souffrent de ce manque de médecins aujourd'hui. Et donc, c'est malheureusement des réformes qui nécessitent beaucoup de temps. Nous avons également beaucoup travaillé sur la gouvernance en mettant en place des structures qui permettent une meilleure gestion de la santé et aussi travailler sur l'indépendance de la gouvernance au niveau de la prise en charge hospitalière, c'est-à-dire que nous avons créé des groupements qui permettent de rapprocher la décision au niveau le plus proche localement dans les régions et qui permet de mieux optimiser les moyens que nous avons. Donc, ayant dit ça, quand on repart au niveau du budget, nous avons un budget qui est passé en l'espace de 4 ans de 2 milliards de dollars à peu près à pratiquement plus de 4 milliards de dollars. Donc, on a doublé même plus notre budget d'investissement. Et nous sommes dans une tendance où nous continuerons toujours à l'augmenter. Ce qui a changé, c'est qu'aujourd'hui, la protection sociale devient non pas un centre de coûts, mais également un vecteur de gestion et de management du système de santé, puisque la protection sociale engage un suivi du financement pour avoir des systèmes qui soient sustainable au niveau financier. Et donc, aujourd'hui, la protection sociale, l'assurance maladie, est un outil qui intervient dans la prise de décision, que ce soit au niveau de l'investissement, mais aussi au niveau de la gestion des coûts, dans la négociation des prix des médicaments, par exemple, qui était un véritable sujet sur lequel nous avions une vue qui était centrée sur le coût des médicaments, mais aujourd'hui, nous avons une vue qui est élargie au protocole thérapeutique, y compris même à la négociation directement avec les laboratoires pour pouvoir optimiser les coûts.
Ok, Monsieur le Ministre, on apprécie cette présentation qui montre effectivement toutes les mesures mises en œuvre et tous les financements mis en œuvre par le gouvernement marocain pour pouvoir améliorer la couverture universelle. Ce qu'on voudrait savoir, est-ce qu'aujourd'hui, ce financement se fait uniquement via le budget de l'État ou vous bénéficiez d'autres appuis extérieurs ou bien vous mobilisez le secteur privé pour accompagner le Maroc pour l'atteinte de ses objectifs?
Alors, le financement, il se fait d'abord majoritairement par le budget de l'État et c'est une bonne chose parce que quand on a un budget de l'État qui est mobilisé pour servir une stratégie de réforme du secteur public, c'est en général un bon signe. Ça veut dire qu'on a correctement défendu notre copie. Mais effectivement, il y a aussi des financements externes qui interviennent, donc des financements internationaux qui sont encore limités malheureusement, mais qui pourraient davantage être impliqués dans le financement de la réforme du secteur de la santé. Le partenariat public-privé est extrêmement important. Le secteur privé peut mobiliser énormément de soutien financier et d'investissement sur lesquels il faut être prêt à l'engager, que ce soit au niveau de l'infrastructure, mais aussi l'infrastructure hospitalière, mais aussi dans des secteurs qui sont tout aussi stratégiques comme la production locale de médicaments, de vaccins. À ce titre, nous avons nous avons initié un projet d'investissement très important pour fabriquer localement des vaccins qui couvrent, j'en avais parlé l'année dernière d'ailleurs, je l'avais même présenté aux assemblées générales de l'OMS en tant que projet, donc une unité qui fabriquait les vaccins. Aujourd'hui, cette unité, elle produit des millions de doses pour le marché marocain sur le vaccin du PCV par exemple, mais également est en train de processer pour fabriquer les vaccins de la méningite, la rage et d'autres vaccins qui sont dans le pipe. Et c'est une unité qui ne couvre que 20% de la capacité du pays. Donc il y a une capacité à s'ouvrir à l'ensemble du marché africain pour pouvoir répondre à ces besoins. Docteur Jean Kasseya, mon ami, a dit dans son introduction ce matin qu'il rencontrait des partenaires qui regardent un peu le marché africain, ou qui disent que le marché africain est peut-être pas assez grand ou non structuré. Nous, on a fait cet investissement parce que nous sommes orientés vers le marché africain et nous sommes conscients qu'il faut avoir une taille suffisante pour pouvoir servir les marchés, optimiser les coûts et baisser les coûts drastiquement pour rendre plus accessibles à la fois les vaccins mais également les médicaments.
Merci, Monsieur le Ministre. Nous allons passer la parole au ministre tunisien de la Santé qui nous parlera de l'impact des dépenses de ménage sur les populations. Comme vous le savez, aujourd'hui, 75% des dépenses directes des ménages impactent sur la vulnérabilité des populations. Et ces mêmes ménages doivent également chaque jour se soigner. Quelles sont aujourd'hui les stratégies, les mesures qui sont mises en œuvre pour pouvoir alléger, comme on dit, le panier de la ménagère afin que les ménages puissent avoir facilement accès aux soins?
Merci beaucoup. Excellences, Mesdames et Messieurs, je suis très honoré de prendre part à ce dialogue de haut niveau organisé par Africa CDC, l'ABAD et l'AUDA-NEPAD sur un sujet devenu central, renforcer l'alliance entre le ministère des Finances, de la Santé et pour faire avancer la souveraineté et la sécurité sanitaire dans les pays africains. Et une conviction nous rassemble, je pense que la santé n'est pas seulement une dépense, c'est un investissement à fort rendement, facteur de stabilité et un moteur de croissance. Et quand un pays finance la prévention, la première ligne, et les médicaments essentiels, la préparation aux urgences, surtout les plus vulnérables, parce que nous avons un système de santé avec plus de 400 000 familles qui ont une gratuité complète des soins dans les 3 niveaux, première ligne, deuxième ligne, troisième ligne, et un nombre équivalent qui ont un régime qu'on appelle une participation symbolique aux soins, plus une couverture de plus de 80% de la population, ou une protection par la CNAM, la Caisse nationale d'assurance maladie. Les ménages participent parce qu'il y a des médicaments qui sont hors nomenclature ou quelques gestes également qui ne sont pas vitaux, mais ça n'alourdit pas le panier ou les dépenses de la famille en Tunisie. En Tunisie, nous avons fait le choix de parler un langage commun entre les finances et la santé dans un cadre de symbiose entre les différents départements du gouvernement avec un régime présidentiel et le chef de l'État qui fixe les orientations et le gouvernement qui exécute la politique, les politiques comme la politique de santé avec une complète synchronisation entre les départements. Et les résultats, c'est dans cet esprit que le ministère de la Santé a été parmi les départements pionniers de la gestion budgétaire par objectif. Donc nous avons des objectifs, un financement par objectif, et on suit selon un agenda la réalisation des objectifs, et les financements de l'année d'après vont être en fonction de l'exécution du budget en fonction de ces objectifs, afin de passer d'une logique de moyens à une culture de résultats mesurables et suivis. Nous assumons ainsi une trajectoire budgétaire claire Aujourd'hui, la santé représente 12% des dépenses gouvernementales et nous continuons à progresser vers l'objectif de moins 15%, conformément à l'engagement d'Abuja. Pour 2026, le budget santé a été rehaussé d'environ 10%. Et surtout, nous travaillons sur la durabilité. Les réformes de protection sociale, les caisses sociales, la CNAM, les caisses de retraite également, et en plus un financement innovant dans un cadre d'équité, de solidarité pour sécuriser la couverture santé universelle. Mais au-delà des chiffres, le cœur de notre message aujourd'hui est simple. Si nous voulons une Afrique souveraine, il faut financer ce qui nous rend souverains. Dans notre plan de 26-30, nous avons structuré cette souveraineté autour de 5 priorités concrètes. Premièrement, la prévention. Comme a été déjà présenté ce matin, la prévention et la vaccination, la sécurité sanitaire et la surveillance, l'approche One Health fait gagner de l'argent. Tout investissement dans cet axe fait gagner de l'argent. Deuxièmement, la réorganisation des soins et le renforcement de la première ligne. Rapprocher les soins des zones rurales, des déserts médicaux, surtout les soins essentiels, et avec transport sanitaire et urgence également. Troisièmement, un paquet de services essentiels et des protocoles harmonisés. Quatrièmement, la transformation digitale. Nous travaillons beaucoup. Ça nous a donné une satisfaction de faire au niveau de notre plateforme de téléradiologie 300 scanners par jour pour 30 régions, essentiellement les déserts médicaux, où il n'y a pas de radiologue, 300 scanners au niveau de la plateforme de l'hôpital numérique, avec 24 sur 24 sur toutes les urgences, 7 jours sur 7 pour les régions où il n'y a pas de radiologue, il y a des scanners, des IRM, des mammographes. Également investir dans l'IA pour la souveraineté des données de la santé et produire une IA qui correspond à l'épidémiologie de nos populations dans le respect de la sécurité nationale des données. Cinquième axe, c'est la santé comme un moteur économique par l'innovation et une régulation modernisée concernant, bien sûr, la fabrication des médicaments génériques. La Tunisie produit 75% de ses besoins avec 43 laboratoires de fabrication de médicaments, avec l'Agence du médicament et contrôle strict de la qualité de cette production. Excellence, si cette session a un objectif, c'est transformer ces priorités en mécanismes de coopération, finance, santé, reproductibles à l'échelle du continent, et les pistes d'action opérationnelles, c'est sanctuariser la préparation aux urgences, acheter plus intelligemment, acheter ensemble également, ça garantit la qualité et les prix et prouver la valeur. Chaque dinar, chaque dollar investi doit être relié à des résultats, accès à la première ligne, disponibilité des médicaments, temps de réponse aux urgences, couverture vaccinale, parcours de soins. C'est là que l'Alliance Finance Santé devient un contrat de performance. Donc, en unissant nos politiques budgétaires et sanitaires, nous pouvons bâtir une souveraineté africaine concrète, celle qui protège nos citoyens, stabilise nos économies et garantit notre sécurité collective.
Merci, Monsieur le ministre. Je trouve un point très intéressant, c'est cette innovation technologique qui contribue aujourd'hui à la couverture universelle dans des régions où nous avons des ressources humaines très limitées. Je pense que ce sont des expériences à partager avec d'autres pays pour pouvoir s'en inspirer. Maintenant, nous venons au Ghana. Bonjour, Monsieur le ministre. Au Zimbabwe, sorry. Au Zimbabwe. Monsieur le ministre, la question est celle-ci. Quelle collaboration entre le ministre de la Santé et le ministre des Finances pour la sécurité des financements mis à la disposition par le gouvernement pour améliorer les soins de santé dans votre pays? Et quelle interface avez-vous avec les partenaires au développement qui, aujourd'hui, réduisent les financements alloués aux États?
Thank you, moderator. I think you saw me listening carefully, but I don't understand a bit of French. And unfortunately, the devices are not working. But I think I heard you mention something about finance. So I think the topic remains that is there collaboration between the ministries of finance to push the health agenda forward. Yes, I think all of us will agree that there is more need for us to focus on domestic financing because of the dwindling donor funds. In our case in Zimbabwe, we started long time ago when the aid scourge was at its highest. We introduced the National AIDS Levy, and it's a modest tax for all the workers who are taxable, and that raises between 50 and 70 million US dollars per year. That has enabled us to actually move preventive and treatment measures for the country, and we have managed to attain the 95, 95, 95 as for the UN AIDS. It also helped us last year when the US government withdrew or announced the withdrawal of its funding. We had to redirect some of those funds, and we were able to prevent any shocks and any disruptions in our HIV programs because of that AIDS levy. There is an act and the funds are ring-fenced. We realized the challenges that we faced during COVID-19, that we cannot rely on donor funds. Countries which had funds had to look after their own populations first, and justifiably so. After that, we have collaborated very well with the Minister of Finance, and we have come up with a sugar tax, which was introduced 2 years ago. And in the first year, end of 2024, we managed to raise $33 million. And this was mainly directed at cancer prevention and treatment. And we've managed to re-equip our 2 centers, one in the northern side and one in the southern side, with new equipment for cancer treatment. We are going forward to now include diagnostic equipment for cancer. We are planning to make sure that we will equip all our provincial hospitals and all our central hospitals with new MRI scans and new CT scans, new ultrasound scans, new mammographs. And we are working with $30 million every year. So this year we are going to the next procurement stage using funds raised domestically. We have also introduced fast food tax. And the fast food tax are mainly targeting NCDs, because we are also seeing that NCDs are a major problem, and we were tending to neglect them, focusing mainly on the infectious diseases. So that's another tax that we've included. But now, on the policy side, we are at the final stage of introducing a national health insurance scheme. We have done the final draft, and we want to introduce it in Parliament anytime soon. Our Parliament opened last week, so we are hoping that we'll get a slot and introduce it. We have realized that out-of-pocket finance is a major problem and creates problems for families, and we have targeted taxes on various things like alcohol, cigarettes, fuel, a lot of things, including airtime, and we think we are able to raise about 112 million from that fund, and then government will top up. We want to say every Zimbabwean can access health services in public institutions for free. We are saying free because the patient doesn't pay, but that fund will then provide the funds to pay for both consultation and treatment, including investigations and admissions. We are going to say every Zimbabwean citizen and every resident This means that we will be able to meet the target of universal health access by 2030 using our own resources. We are also targeting funds from mining, from agriculture, and from timber to add on to the pocket. So this can only happen with the collaboration with Ministry of Finance. And also for release of funds, we have set up a committee chaired, co-chaired by the Deputy Minister of Health and the Deputy Minister of Finance, and they meet weekly to make sure that funds are being released to channel to the priority areas that we have. So there is collaboration between the Minister of Finance and the Minister of Health to finance health issues. I think we started very well, and we hope if this progresses like that, we'll be able to cover our health needs within the next 2-3 years. I thank you.
Merci, Monsieur le Ministre. C'est tellement intéressant, votre exposé. Ce que je retiens au terme de ce panel est que les États restent engagés dans la couverture universelle aux soins au niveau de la population africaine. L'engagement reste réel, mais aussi que nos différents gouvernements continuent à faire des efforts importants pour pouvoir sécuriser les financements alloués au système de santé afin que les pays deviennent souverains, et aussi tous ces financements innovants tels que l'a présenté tout à l'heure au niveau du Zimbabwe, le ministre du Zimbabwe, mais aussi toutes ces innovations technologiques qui contribuent à améliorer le système de santé. Donc, une fois de plus, merci. Je demande de pouvoir féliciter nos différents panélistes qui ont brillamment participé à ce panel. Nous sommes... il y a une dernière intervention, vous le permettez ou bien? Ok, rapidement, 1 minute.
Yes, we've all spoken about how government is using government funding to fund the health sector, but there's one thing that we are doing in Ghana at the moment that I think that we all need to share, is the involvement of the private sector, PPP. So for example, in Ghana, my government inherited some ongoing projects. So what we are doing is that we're inviting the private sector, irrespective of the stage of the project. We say the private sector can come in, the government will have an agreement with the private sector. You take the infrastructure, you finish, you equip, then you run. The government will have an agreement with you, maybe build, operate, and transfer, maybe 2 years or 10 years or 20 years, depending on, the amount government has also expended in it. And again, we also realize that government buy equipment, they give to the health facilities. Years later, we demand money from government to maintain the equipment or to replace the equipment, and that is not sustainable. So what government is doing at the moment is that we're establishing what we call special purpose vehicle. So when you establish the special purpose vehicle, you then delink the management of the equipment from the management of the hospital. So the management of the equipment is managed separately from
Rapidement, Monsieur le Ministre.
Thank you very much.
Merci. Le ministre nous a partagé l'expérience du Ghana dans la collaboration avec le secteur privé. Donc, merci pour ces leçons apprises, merci pour ces expériences partagées et à très bientôt. Merci encore je voudrais remercier à titre personnel mon cher ami Jean Kazéa qui m'a fait l'honneur de présider ce premier panel, et je voudrais conclure en paraphrasant une de ses phrases qui dit « L'Afrique doit définir ses propres priorités en matière de santé, mettre en œuvre ses propres solutions et financer sa propre résilience de l'intérieur. Ce n'est qu'ainsi que nous pourrons atteindre cette souveraineté. » Je vous remercie.
Thank you so much, Excellencies. What a great session. So, Excellencies, distinguished colleagues, ladies and gentlemen, we move straight to the next panel, but before that, just a quick photo. So, the next session will be moderated by His Excellency Dr. Michel Sidibe, former minister, former UNA, former special envoy. And Dr. Michel will be joined by ministers from Central African Republic, DR Congo, Djibouti, Ethiopia, Rwanda, and South Sudan.
Il était le seul qui était là. Ça va? Anglais, yeah, Anglais, yeah. I decided that I will make it in English.
Yeah. 15 minutes, Prof.
Yeah, 15 you said. Yeah. It will be very quick. They know me.
Okay. Just need to press the button.
This one is working. Only yours is working. Thank you very much. Let me just start by saying that it is an honor and pleasure for me to moderate this session. And I want to thank, of course, CDC and AUDA-NEPAD, my sister and my brother, to let me have the opportunity to be here. And I started by saying to this young man who was introducing me that when he will reach my age, he will realize that in his CV, it will have a lot of former. So saying that one, I don't want to take too much time because we are already late in the program, and he told me to manage this session in 15 minutes. You can imagine that I am ambushed. So I was thinking that I could introduce a little bit this topic because it's a central topic. Is one of the most topical from my point of view and timely because the shift from dependency to sovereignty is not just a rhetorical word. It should be translated into our daily way to deal with our health system and our health financing and how we interact with the Minister of Finance and others. But I am privileged to have people here, ministers, who are just navigating every day in these complex fiscal realities. And while protecting and strengthening, I can say, the health of their people. I will not take too much time. I will just say that improve efficiency, like it has been said today, and drive lasting impact is certainly the ultimate goal we all want to achieve. So I will start with you, my brother, Pierre, if you want. Pierre and Djibouti. Djibouti is here also or not? Yes, my brother is here. So both of you, I will ask the same question. So because I have only 15 minutes to manage that, so I will not ask to each of you one question. So the main question I want to ask you is that out of pocket, like it has been presented today, is very high in many countries. Out of pocket spending remain very, very high in Djibouti and also in CAR. What measure are you prioritizing to reduce the financial burden on household, dear brother Minister Pierre, and then my brother from Djibouti?
Merci Michel. D'abord, félicitations à Africa CDC et NEPAD et l'ABAD pour cette initiative vitale qui arrive au bon moment. Je viens de deux grandes réunions à Genève, le comité exécutif de l'OMS et le conseil d'administration du Fonds mondial. Et cette réunion ne pouvait pas venir à un meilleur moment. Et donc, félicitations, parce qu'il faut que les dirigeants africains affirment aujourd'hui que la santé est effectivement un moteur de croissance. Il ne suffit pas seulement de collaboration entre le ministre des Finances et le ministre de la Santé. Nous, on a des exécutants. Mais il faut qu'au-delà de cela, au niveau national, que la santé soit affirmée. Et je suis content que le document, que la thèse que nous voulons défendre aujourd'hui ici, à la base de cette réunion, c'est cela. Alors, en ce qui nous concerne, le coût de out of pocket est élevé. Il est à presque 50%, peut-être 50%, alors que l'OMS demande un maximum, un plafond de 23 à 25%. Donc chez nous, effectivement, la santé est en train d'appauvrir les ménages. Et les ménages sont asphyxiés. L'argent va seulement pour la santé. Et quelle santé, quelle qualité? Non seulement ils dépensent, mais ils n'ont pas le retour qu'il faut. Et ça, nous en sommes conscients au niveau du gouvernement, qui est très engagé. Et nous avons une stratégie de financement qui a été approuvée par le gouvernement. Nous avons un comité santé-finance mis en place par arrêté interministériel approuvé par le gouvernement, qui aujourd'hui guide notre réflexion commune. Nous sommes en train de mettre en place une stratégie d'assurance maladie qui est déjà approuvée par le gouvernement. La feuille de route est en cours. Donc, voilà tout ce que nous sommes en train de faire. Mais ce qu'il faut dire, c'est que nous avons des opportunités, nous avons énormément d'opportunités qui doivent être mieux utilisées. Non seulement les ressources de l'État, et mon collègue du budget de finances va dire un peu ce qu'il fait, mais nos partenaires qui nous aident beaucoup devraient nous aider mieux. De telle sorte que les ressources qu'ils mettent à notre disposition soient...
Vous aider mieux.
D'abord, premièrement, il faut qu'ils affirment que la santé est moteur de croissance. Je suis heureux que la BAD fasse partie de cette initiative. Mais la BAD n'est pas le seul acteur. On a la Banque mondiale, on a la FMI, on a d'autres banques. Ils doivent affirmer, pas seulement sur papier, mais dans leur institution. Et je sais que dans la Banque mondiale, par exemple, on affirme, mais ce n'est pas vrai. La santé n'est pas un moteur de croissance. Ça, je l'assume. Et il faut que nos partenaires affirment ça. Et c'est comme ça qu'ils peuvent appuyer nos pays à développer leur politique macroéconomique.
30 secondes.
Oui. Alors, une autre chose aussi, c'est ce que déjà le rapport du CDC, Africa CDC, a mis en exergue. La verticalisation, la fragmentation qui nous impose. Mais surtout aussi, le fait qu'ils ne font pas confiance au gouvernement. Beaucoup remettent leurs ressources à des ONG qui n'utilisent pas ces ressources-là de façon efficiente. C'est de l'argent gaspillé, jeté par la fenêtre. Il faut qu'il y ait la confiance. Il faut qu'il y ait le respect des pays. Et alors, pour que ce problème soit résolu, nous, on doit se faire respecter. Les pays doivent se faire respecter. On doit être capable de dire non à des ressources qui ne nous servent à rien. Parce que, justement, ces ressources-là, jusqu'ici, ne nous ont pas fait avancer.
Fini tes 30 secondes.
J'ai fini. Merci beaucoup.
Merci. Excellent, Pierre. Je pense qu'il y a toujours cette passion que je retrouve. Ce qui est très important, il ne faut pas perdre cette passion-là. Et surtout, ce que tu as essayé de nous expliquer, c'est que dans un contexte difficile comme celui de ton pays, tu essayes de trouver des mécanismes qui peuvent permettre de soulager au moins les populations. Je passe le micro à mon frère de Djibouti. Ah, il a son micro.
Oui, je laisse. Merci beaucoup, Dr Sidibé. Excellences les ministres, les directeurs généraux de CDC, tout protocole observé, bonjour. D'abord, je dois remercier et surtout féliciter le CDC Afrique d'organiser chaque année ces types de rencontres où les ministres de la Santé des pays africains et maintenant ceux du ministère des Finances donc, discutent sur le financement de la santé. Je pense que c'est une belle opportunité d'échanger des idées. Je pense que si l'État finance correctement sa santé, je pense que l'argent qu'on cherche au niveau des populations va diminuer. Il faut d'abord considérer que la santé est un droit. Ce n'est pas des choses qu'on négocie, ce n'est pas de la charité. La population, toute population a droit à la santé. Et il faut que d'abord les dirigeants puissent comprendre ça. À Djibouti, qui est un petit pays de l'Afrique de l'Est, de plus en plus, les out of pocket diminuent drastiquement. Diminuent pourquoi? Parce qu'il y a un certain nombre de mesures qui ont été prises. D'abord, c'est l'assurance maladie. Chez nous, l'assurance maladie est une réalité depuis maintenant une vingtaine d'années. Et cette assurance maladie de plus en plus augmente. Actuellement, elle est autour de 45% de la population. Qu'est-ce que ça veut dire? C'est qu'au niveau le système de santé primaire et au niveau des hôpitaux, les Djiboutiens ne payent pas d'argent. Tout est gratuit, c'est-à-dire toutes les prises en charge que nous faisons au niveau des hôpitaux et surtout dans les zones très reculées, la santé est gratuite. C'est la CNSS, c'est la Caisse nationale de sécurité sociale qui paye le ministère de la Santé et donc c'est gratuit. Donc c'est un premier levier vraiment pour diminuer les out of pocket et on prend en charge également maintenant, cette assurance maladie est même élargie aux réfugiés et aux migrants même. Le deuxième élément, c'est ce que le ministre, mon collègue tunisien l'a dit, c'est de passer un budget, nous avons passé un budget programme. Avant, on avait un budget moyen, c'est-à-dire on avait un certain nombre. Alors, qu'est-ce que ça veut dire? C'est qu'avant, on faisait nos programmes avec l'argent qui était disponible. C'est-à-dire qu'on disait on avait besoin de telle somme, de telle somme, de telle somme. C'est fini maintenant. Nous sommes passés à un budget programme où nous devons faire un certain nombre de projets sur l'argent qui est disponible. Et l'année suivante, nous sommes testés, nous sommes, c'est-à-dire en fonction des résultats et des performances des projets de l'année antérieure, qu'on vous donne un certain nombre de moyens. Si vous n'atteignez pas ces objectifs-là, vous n'avez pas de l'argent. Et donc, ça force le ministère de la Santé à atteindre un certain nombre d'objectifs. Donc, c'est pour ça que nous appelons, avec le ministère des Finances, nous avons un programme sur 10 ans sur le budget programme. Et enfin, c'est le dernier élément, c'est les taxes sur un certain nombre de produits. Nous avons commencé à taxer l'alcool, le tabac, le sucre, l'huile, un certain nombre de produits, et ça permet de financer la santé. Ceci nous a permis à Djibouti d'augmenter vraiment le budget. Nous sommes actuellement autour de 8%. 8% de financement de la santé. On était à 6% il y a 4 ans. Actuellement, nous sommes à 8%. Et chaque année, nous allons continuer donc à augmenter, Inch'Allah. Je vous remercie.
Intéressante, mettant l'accent sur l'assurance maladie, l'approche programme, et puis tout ce qui peut permettre de soulager les conditions des populations les plus démunies, en insistant sur les questions de droit. Je vais passer, sorry, let me move quickly because they give me 10 minutes only, 15 minutes for the facilitation. DRC and Ethiopia. I will take, with the fiscal pressures and declining external aid, what concrete step have you taken to protect or increase the domestic health financing, and how are you working with your Ministry of Finance? We start with the lady.
Thank you, moderator. The first thing we did and what we did was to do an in-depth analysis. Especially after COVID, an external finance has already reduced. We know the ODA shift, but knowing where exactly are the high impact but most vulnerable areas was the first thing we did. So we did a higher level group with Minister of Finance, Minister of Health, other sector ministries with ministerial council at the level of the Prime Minister level. And then what we took was a deliberate step to protect the essential services, to protect the most vulnerable areas. So we looked into critical steps of coordination, and we used existing coordination platforms. We have a one plan, one budget, one reporting mechanism in country, as you know, but there are still programs that weren't in the one plan, but one reporting mechanism. So just post that period, and exactly after this ODA shift, what we did was looking at recognizing where the dependency was and shifting with innovative financing. We had a one-on-one matching, for example, or RMNCH, where we mobilized 300 million USD, and we also ensured that 100 million USD was also injected as a subsidiary to the programs we have that are existing. And an additional thing that we did was also the HRH Compact. With this, for some we did one-on-one, for some like HRH we did with the regional governments also. So I'll be really quick in saying that the HRH Compact, the RMNCH Compact are some of the essential areas, but the pooled mechanism that we have with SDG pooled financing that was already existing in country was potentiated by other pooled mechanisms we have, both at global, regional, at the country level. So the most important thing is going to be about trust. Is the mechanism working? Do we have a visibility? Do we have integration? The only integration platform is going to be about aligning with national priorities. So we set our priority clear, we communicated with our partners, and we set our UHC agenda as an umbrella. We're committed with the UHC umbrella, with Global Fund, other institutions with Pandemic Fund, other global entities for a pooled mechanism, World Bank's UHC umbrella. Then we pooled everything as a national health sector transformation and investment plan. Now we're at a one-on-one matching to look at how much should we invest. Good example that I would want to use at this table is to say, let's trust the regional coordination mechanism, let's trust the global coordination mechanism, and let's look at national pooled mechanism for financing. And this Minister of Finance will take, and we've used it with Marburg, and I want to say thank you for all who supported us when the country led and when we delivered to our promises during the Marburg fight. Thank you.
Thank you very much, Megdas. In 1 minute, you managed to just share important information to us. And particularly that remind me when I launched with UNAIDS those days, the 3-1. So very important point that this 3-1 is back and will help us certainly to have more efficiency by coordinating, by having one budget and one monitoring and reporting system. Excellent. My brother.
Merci beaucoup. Je vais aussi aller très rapidement. D'abord en remerciant CDC Afrique et puis surtout mon frère de la RDC, Jean Kasseya, qui nous permet effectivement de nous présenter ici et de nous unir pour répondre à ces différentes questions. Alors pour la RDC, très rapidement, nous avons d'abord intégré d'abord nos priorités parce qu'il faut quand même savoir ce qu'on fait de l'argent. Et nous avons dans notre plan national de développement sanitaire intégré d'abord nos priorités, nous avons hiérarchisé nos dépenses et puis nous avons regardé les ressources que nous avions. Nous avons réussi à demander au Parlement d'augmenter le financement en santé et notamment l'investissement. Mais malgré tout, cela est resté insuffisant et nous avons pris 2 mesures importantes. La première, c'est que nous avons obtenu du Parlement et puis du gouvernement en général une taxe de 2% sur tous les produits importés en RDC, sauf les produits alimentaires. Et cela permettrait que nous puissions mobiliser plusieurs centaines de millions de dollars par an parce que c'est vraiment tous les produits importés qui donnent 2% au secteur de la santé. Nous avons aussi mis en place l'assurance maladie obligatoire qui nous permettrait aussi de mobiliser plusieurs millions de dollars. Et nous estimons que pour 2026, par exemple, nous devrions atteindre autour de 1 milliard de dollars. Donc, ça montre l'effort très important. Mais nous ne sommes pas arrêtés là. Nous avons regardé le côté du secteur privé. Et nous avons proposé quelque chose au secteur privé. Nous avons dit, dans la mesure où nous avons une économie informelle très importante, nous voulons participer à l'inclusion financière de la population dans l'économie formelle. Et pour cela, nous avons proposé aux banques et aux services privés de produire une carte de santé qui est en même temps une carte de banque. Et au début, c'était difficile à comprendre, mais je peux vous assurer que Visa International
Et Mastercard International nous ont suivis en décidant de préfinancer chacun 20 millions de cartes. Ça veut dire que nous allons amener dans l'économie formelle plusieurs dizaines de millions de Congolais qui étaient dans l'économie informelle. Ça permet d'élargir l'assiette fiscale et finalement d'augmenter les ressources en santé. Donc nous avons fait cet ensemble de mécanismes pour pouvoir mobiliser dans un contexte où nous avons vu diminuer les ressources extérieures et dans un contexte où la RDC était vraiment dépendant des ressources extérieures et de out of pocket. Donc actuellement, nous sommes en train d'attendre que nos partenaires s'alignent sur nos priorités que nous avons intégrées, que nous avons hiérarchisées, de telle sorte que l'ensemble des moyens mobilisés nous permettent d'atteindre les objectifs que nous sommes fixés.
Excellent. Merci encore une fois d'avoir été très clair et très précis. Prioriser d'abord et essayer de faire en sorte qu'on soit très clair sur les objectifs, mobiliser des ressources internes, les allouer de façon plus efficace et plus efficiente. Merci beaucoup. Et je pense que ça, c'est un point très important. Je passe tout de suite à Yvan. Yvan, je crois que je peux parler en français avec toi et en anglais, c'est la même chose. Je crois qu'il n'y a pas de problème. On a un problème particulier un peu partout aujourd'hui avec, bien sûr, un espace fiscal qui est assez difficile et qui n'est pas facile parce qu'on a des restrictions et il faut nécessairement aller vers une plus grande efficacité de toutes les ressources que nous avons. Et qu'est-ce que vous avez porté comme réforme pour faire en sorte qu'en réalité, on puisse aller vers une meilleure utilisation des ressources dépensées dans le secteur de la santé?
Merci Michel. Comme tu as posé
Je
la question...
sais que tu as besoin de plusieurs minutes.
Je vais essayer de faire ça en 1 minute.
Tu es gentil.
Merci. Comme tu as posé la question en français, donc je vais répondre en anglais pour qu'on puisse...
That's excellent.
Right, so two guiding principles that we base on in Rwanda to deliver healthcare. One is access to all and at an affordable price or cost. So that's just the vision for it. And now when you go into implementation, what does it mean tangibly? So I think what we did is to put in place evidence-based interventions. So they have to be significant evidence before we launch something. It has to be high impact and it has to be cost effective. So I'll use examples. In Rwanda, we have a large network of community health workers because we believe that primary healthcare is the driver of delivery of health. And these community health workers right now, as we speak, are using digital tools to be able to know what's happening in their communities. And the digital tools that they use are connected up to our offices where we have the Health Intelligence Center. I'm able to detect something that is mushrooming somewhere ahead of time. Because the time we are in right now, we cannot afford to have blanket interventions for the entire country. It has to be targeted, specific, responding to specific needs. And you cannot do that without having data. So that's what we're doing, heavily investing in data, detecting things before they go out of control, being able to map and knowing which interventions will go where. So for instance, and that's where the private sector comes in, because you have to know what are you good at as government, what is private sector better at. So for malaria, which is endemic in the region, we're currently using private sector that is deploying drones to be able to detect high vulnerable areas where you have mosquito breeding sites that will probably drive an outbreak of malaria. And once you have an outbreak of malaria, it really consumes a lot in your expenditures. So they detect ahead of time, then drones deliver insecticides there, and you don't have to spray across the country, and you have a lot of spending, of savings. So that's what we're doing. So it's innovation, it's data, it's technology, it's coordination with everyone. We agree on what we're going to do. We cost it, we go and we implement. And there's an important thing, which is execution is extremely important. Discipline of execution drives everything, proper planning, but discipline of execution. So after that, that's what we're doing, is also seeing how with the emergence of non-communicable diseases, because in Rwanda, 95% of people have access to healthcare. But right now, this year, we increased the package of services where cancer right now is covered in the community-based health insurance, dialysis services, transplant services, cardiac surgery interventions, because these are contemporary issues that we have, but they still have to fit in the basket of community-based health insurance. And the fund is being now funded with more, so traffic fines, if you pay a traffic fine, some portion goes to the health insurance, the banking sector, the telco sector are contributing there. So and just sharing those experiences, and that's how we are.
Thank you. Thank you. And you help really to summarize data, innovation, and improve service delivery. Thank you very much. I will move to Sudan and just South Sudan to really ask you in this complex context. I can say that where fragility is present, and competing priorities are there. I've been in South Sudan in many occasions. And how is your government protecting health financing, and what strategies are helping sustain essential services and preparedness?
Thank you. Yeah, it's my pleasure to be here at the 39th AU Summit. And I believe the message since morning is that Africa can no longer afford to treat health as a social expense. We must treat it as a strategic capital investment. As you mentioned, yes, South Sudan is really a case, it's a test case for resilience. We are moving from health care support to a national health recovery strategy. It's not been easy. We are regional health security asset. We currently manage 1.3 million refugees from the Sudan crisis. And we see that if South Sudan's health system remains underfunded, it creates a security vacuum. Especially with the outbreaks of cholera, measles, and mpox. In South Sudan, we really focus on providing free primary health care for everyone, especially through the Boomer Health Initiative, which is a community health initiative. We rely mostly on our donors, but in 2025, just at the end of this year, of last year, we have faced a funding cliff. Major donors suspended critical contracts, and that is threatening actually 1,000, almost 1,200 facilities under the health sector transformation project. Given South Sudan's status, it requires us to really do a lot and reach out to support from within. We look at the Africa Development Bank, and we need blended finance to rebuild 157 facilities destroyed by floods due to climate change. And we hope that these facilities will become a climate smart clinics. And also with the private sector, it's important that we are proposing remote service incentives, tax exemption and security guarantees to attract private operators, especially to flood-affected areas through public-private partnerships. And of course, the regional partners are important. We call for a health workforce fund to stabilize salaries for our dedicated health workers who face and who have faced months without pay. So South Sudan is actually really going through difficulty, especially being a fragile state, but we continue to collaborate with our partners and with our Ministry of Finance. We offer efficiency and accountability, and we have, through our expanded DHIS2 digital system, we are now linking 65% of our facilities to the system. And we are proving our absorptive capacity to track every dollar spent. yeah, our system is struggling, but we as the government is committed to improve the health of the population, and our team will use the Africa CDC AHSS agenda on our framework to build a national recovery strategy. So the message that I would like to share is, yes, South Sudan is going through difficulties, but it is a test for a case for resilience. Thank you.
Very much. Thank you very much. Excellent presentation and showing how the context is difficult, but the commitment and the fight of the government to really make sure that ownership could continue to be a central part of whatever they're doing is an important message you share with us. I want to just say thanks to all of you. Sorry, this panel, excellent panel, could go on and on and on, but unfortunately in 15, 20 minutes is very difficult to take advantage of all the things you could share with us, but we have been able to learn a lot. I want to take advantage to thank also Kasea for his personal leadership and organizing this type of interaction, which is so critical for all of us. Coming from different parts of the continent, learning from each other is a key for making sure that we can have a unified voice. If I have only one message I took from this whole presentation, it will be that health security cannot be outsourced. And certainly universal health coverage cannot be imported. So let us build our own mechanism to make sure that we own our system and we position our vision like the guiding principle for anyone who wants to help us. Thank you very much.
That great session. Excellencies, colleagues, ladies and gentlemen. So it's now time for the panel session of our Ministers of Finance. And to moderate that will be no other person than Dr. Amit Taka, the CEO of Africa Health Business, all the way from Nairobi, Kenya. And the member states who will be joining this session are Nigeria, Chad, Gambia, Burundi, Congo, Madagascar, and Tanzania. Nigeria, Chad, Gambia, Burundi, Congo, Madagascar, and Tanzania.
Thank you, thank you. Yes, Raj.
Sorry, Minister of Finance of Central African Republic. Your Excellency, please join us on stage.
Your Excellency, please join us on stage. Thank you, Tajdin. Thank you so much. I know we have limited time, but I want to get cracking. And like you've seen earlier, the panels have been really difficult to manage within the 20, 30 minutes. So we'll try our best. We'll have a conversation. So Your Excellency, ministers, friends, ladies and gentlemen, champions of the industry, it's a brilliant room. So let me just say, on behalf of all of us, all protocol observed. So we don't have to go into any protocol, honorable ministers. Every protocol is observed. We are actually, as health people here, very fortunate to have finance people because the nexus is very, very clear. Since morning, we have heard about Africa's health, security and sovereignty and the ambition. We've also heard that the fiscal space is becoming very difficult with everything around GDP to debt ratio, to issues around direct access to health financing, ODAs declining. But what we've also heard is a sense of urgency from your colleagues of ministers of health that we need to deliver these services to our people. And many people on the panel earlier said access to healthcare for all. Now we know that access to healthcare for all does not come free of charge. And you are in the center of ensuring that we get the right amount of money. Do we need more money for health? The answer is yes. And health is an investment. But do we need more health for the money you already give us? You also heard earlier that we could do well in financing and delivering better healthcare for the funding that we get from you. My question, and I'll do around, so we have both French and English, so be ready with your, I really want to ask you a candid question. Please be honest with us. Feel free. What can the ministers of health do better to propose a higher contribution towards health in their own countries? And what has your experience been when we are looking for more funding from the Ministry of Finance? Be honest, what's going well and what is the challenge? And I'll start with you, Madam, from Nigeria, and then we will go that way. And the second question will be around UHC, and I'll come this way. And I'll give you, can I just say, try and keep your answers short so everybody gets a chance to speak. So if I can give you 2 minutes to respond, and I'll come back this way.
Good afternoon all. I think keeping it short, there are 3 things that I'd like us to do better with the Ministry of Health. One is really, when we talk about closer collaboration and coordination, I don't want it to be just something on paper. Quick, there's an element of ensuring that we understand each other's issues and we co-create the solutions so that we can, and it really needs to be at the strategic, the tactical, and the operational levels. You know, it's very easy, certainly where we come from, that people say, okay, let's set up another committee. That's not what we're suggesting. We know that there are existing frameworks and structures that we can use. Let's use them and ensure that we're working more closely together and effectively. The second one is prioritization. Again, let's work together on the prioritization. What should we be spending on? What will really move the needle? We're speaking about efficiency. How can we be more efficient with the spend? But equally, even we as the Ministry of Finance, for example, we've got AFDB here, we're asking ourselves, okay, how can our spend be more catalytic? How can we ensure we're spending on, for example, counterpart funding so that that would unlock more, greater resources? And the third for us is about the innovation. We're talking about blended finances, but let's also work together to ensure we have investment-ready initiatives. We saw our Sovereign Investment Authority, they partnered with IFC to work on cardiology and diagnostic facilities across. How can we do more and more of that? And I'll leave it at that.
Thank you. That is succinct and great. Can I come to it? Congo, right? Yep.
Yes, I'm going to speak in French. Merci beaucoup d'abord aux organisateurs pour cette initiative sur un sujet extrêmement important et qui permet de lever un quiproquo. Les ministres des Finances ne sont pas par définition contre les dépenses en faveur des secteurs sociaux. Nous pensons aussi que la santé est un investissement. Et en effet, il y a souvent des dialogues, mais parce que vous l'avez rappelé, les contraintes macroéconomiques sont très fortes. Je prends un exemple pour un pays comme le Congo. En 2020, la dette représentait 107% du PIB. Une fois que vous avez un tel niveau de dette, ça rend les discussions compliquées, pas seulement avec les ministres de la Santé, mais avec tout le monde. Aujourd'hui, nous sommes à 90% du PIB et en 2029, on sera à 70% du PIB. Et ce que l'on observe, c'est que nos dépenses en faveur de la santé ne cessent de croître. Aujourd'hui, ça représente 10 à 11% de nos dépenses budgétaires et 2% du PIB. Et je pense que ça va continuer à croître. Maintenant, qu'est-ce qu'il faut faire pour que, du côté de la santé, ce dialogue puisse s'améliorer? Je pense que la première chose que j'aurais envie de dire à mon collègue, alors je peux parler librement puisqu'il n'est pas là, c'est que d'abord, il faudrait être plus inclusif. C'est que dans les discussions que nous avons autour des conférences budgétaires sur le secteur de la santé, il ne faut pas que le ministère de la Santé ne pense qu'à lui. Justement, les autres secteurs qui ont un impact sont tout aussi importants. Investir dans l'eau, dans l'assainissement, dans l'éducation, ça a un impact au final sur les indicateurs de santé. Donc il faut que du côté du ministère de la Santé, on soit prêt à avoir cette approche coordonnée et avec un focus sur les résultats. Et en se disant, ces résultats peuvent venir aussi du travail qui est fait avec les autres ministères concernés. Par ailleurs, il faut également, ce que je recommanderais également à mes collègues, c'est d'être ouvert justement aux solutions qui peuvent venir du secteur privé. Le secteur public n'est pas supposé tout fournir, apporter lui-même toutes les solutions. Et il faut donc que l'approche des PPP, des ouvertures au secteur privé, ne soit pas qu'une affaire portée par le seul ministère des Finances, qui doit être à la pointe de l'innovation, etc. Mais le ministère de la Santé lui-même doit pouvoir être engagé dans un dialogue avec le secteur privé pour trouver des solutions en la matière. Et puis enfin, il faut en effet une définition très claire des priorités et de la politique. On sait qu'un système curatif coûte beaucoup plus cher qu'un système préventif. Donc investissons beaucoup plus dans le préventif, comme ça pourra alléger le poids sur le budget. Voilà ce que je peux dire en 3 mots. Merci.
That was very good. Some of cross-cutting. Can I come to Madagascar, Honorable Minister?
Yes.
2 minutes.
Merci beaucoup. Donc, je ne reviens plus sur le constat présenté tout à l'heure, mais donc je reprends donc le mot mindset. Donc, le mindset, c'est très important en matière de finances publiques pour financer la santé, c'est-à-dire donc dans le contexte de contraintes budgétaires. Donc, si nous regardons en Afrique, notre taux de pression fiscale est très faible. Et en particulier, par exemple, pour Madagascar, c'est 10,8%. Et nous pensons que la question n'est pas seulement de l'élargissement de l'assiette fiscale, mais surtout de la lutte contre les fraudes fiscales et les fraudes douanières. Parce qu'à Madagascar, on estime à peu près à 4% du PIB les fraudes fiscales. Donc, il faut donc rationaliser nos dépenses et faire des efforts pour lutter contre les fraudes fiscales. Deuxième point, il ne faut pas considérer le problème de santé de manière isolée. Il faut l'intégrer dans le contexte du développement économique. Nous savons tous que dans les années 60-70, nous avons atteint un bon indicateur social en termes de santé et d'éducation. Mais comme nous n'avons pas vraiment un plan de développement économique réaliste, nous ne savons pas utiliser ces capital humains-là et nous revenons dans un problème économique et tous les indicateurs sociaux se dégradent. Donc, il faut donc entrer dans le contexte de développement économique. Il faut intégrer le plan de santé dans un plan de développement économique. Et ensemble, il faut considérer donc toutes les actions de développement parce que si on considère seulement à la santé, on y donne beaucoup d'argent. Mais si la croissance est faible comme aujourd'hui, donc il n'y aura pas de résultat positif. Donc, il faut donc que nous intégrons le plan de santé dans le plan national de développement économique. Donc, c'est ce que nous allons faire à Madagascar actuellement. Merci beaucoup.
Thank you so much. I'll come to Honorable Minister from Chad. What is your message? Again, let me go back to the question. To the Ministry of Health, what can we do better?
Merci, merci beaucoup. Moi, je voudrais profiter également pour remercier les organisateurs qui nous ont permis aujourd'hui de discuter de ce problème très important de la santé en Afrique, surtout dans nos pays. Je me félicite également que tous les ministres de santé qui ont passé ont soulevé la bonne collaboration, le dialogue avec le ministère des Finances. Je n'ai pas vu un ministre poser des problèmes entre le ministère des Finances et le ministère de la Santé. Donc cela veut dire que nous collaborons, nous dialoguons et surtout dans nos pays comme le Tchad, nous avons des sous-sections d'arbitrage et de conférences budgétaires exclusives avec les secteurs sociaux comme la santé, l'éducation, l'eau, l'assainissement. Donc le dialogue est permanent, mais par rapport à la question, une population, pour moi, une population en bonne santé est une population productive, résiliente, capable de soutenir durablement le développement économique, social du pays. Donc, dans un contexte de contraction de l'aide extérieure et de pression sociale forte, nous devons repenser le développement de notre système de santé. Et c'est pourquoi nous, au niveau du Tchad, nous avons opté à beaucoup de processus, surtout en ce qui concerne la gratuité des soins, pour essayer, parce que nous avons des populations vulnérables. Et il faut souligner en passant que le Tchad est confronté à une situation un peu plus difficile avec l'accueil de réfugiés et de retournés conséquences de la guerre au Soudan. Et dans le souci de solidarité et d'engagement.
Honorable Minister, sorry, we have very limited time.
Yes, yes.
What I want from you,
yes, yes.
Let's
donc,
go back to the question. What is your advice to the Ministry of Health? Because we have other
oui. Oui, le ministère de Santé, je pense que nous proposons avec nos ministères de Santé de créer des cadres de dialogue permanent entre le ministère des Finances et Santé, s'assurer que les priorités sont définies dans le plan national de développement du Tchad, parce que là, le plan national a fait une part belle à la santé et surtout aux secteurs sociaux, instaurer les disciplines de résultats basées sur la performance, améliorer l'efficacité et l'efficience de la dépense publique de santé, assurer une meilleure prévisibilité et soutenabilité du financement, parce qu'il faut qu'il y ait soutenabilité, renforcer la transparence, la redevabilité et la bonne gouvernance des ressources, aligner les investissements sanitaires sur les priorités économiques, sociales et démographiques du pays. Et enfin, ce que nous proposons, c'est de privilégier les partenariats publics-privés que nous estimons au niveau des finances, parce que notre ministère, c'est le ministère des Finances, de l'économie, du plan et de la coopération internationale, comme une source de financement innovante, comme également nous préconisons Au Tchad, aujourd'hui, nous avons mis en place le système national de sécurité, de santé universelle que nous finançons avec des taxes dédiées sur tout ce qui est importation de certains produits nocifs comme le tabac. Donc voilà, et je voudrais vraiment dire que nous travaillons en étroite collaboration avec le ministère de la Santé pour essayer de résoudre tous ces défis au niveau de la santé. Merci.
Thank you so much, Honorable Minister. We move to Tanzania. What is your call out to the Ministry of Health?
Thank you. First of all, I have to also say that Tanzania, we take health as a crucial and integral part of human capital development.
Well done.
The importance for health cannot be overemphasized. We appreciate that.
Excellent.
But in terms of the message, I think the first one will come from the presentations this morning. We have gains that we can make from the improvement on efficiency. If at the moment we lose between 20 and 40% of what has been disbursed to the health sector, that means even with the little that we have, we can do more. So I think that will be the first thing. Secondly, there has been a lot of very good practices across the continent. We need to, look at the kind of peer learning from each other, what has worked where, and what can be avoided in different regimes. Third, in terms of a lot of alternative financing methods, we may also need to look into these, especially when it comes to merging very different funds. I think in different countries there are multiple funds that are addressed to health. Even in Tanzania, we have HIV, AIDS, we have General Health Fund. We also have another fund, so probably about around 3 funds. Maybe this could be consolidated into one. Finally, I think we need also to look into sector, to health as in a broader perspective. The investment, I haven't really heard from the presentation this morning, the investment that we do on defensive health financing. When we spend on water, potable water, clean and safe water, this has a lot of connotation in terms of diarrhea and other waterborne diseases. When we invest on agriculture, that will bring food and nutrition, that improves health. And when we invest on hard infrastructure, roads and whatever, it actually helps in terms of
safety,
connecting the health delivery system that we have, from primary to district to regional, even to referral health systems. So all this investment has to be taken into account when we think about health investing. Finally, if health is an investment, we also have to look on amortization. When we talk about debt services, debt repayment and services, we actually do not unpack what now we pay now that has actually gone in the past to health services or health infrastructure and what I have. I think this will be my key message.
Thank you so much. Honorable Minister, your message to the Ministry of Health?
Je représente le ministère des Finances au Burundi. Et merci, monsieur le modérateur, de poser cette question qui est très intéressante pour le développement de la santé. Le gouvernement du Burundi a entrepris plusieurs réformes pour le développement du capital humain, dont le ministère de la Santé est le leader. Le ministère de la Santé a entrepris la promotion de la santé pour tous, de l'éducation pour tous, de la lutte contre les pandémies qui surviennent d'une manière intempestive. Alors, compte tenu aussi de le détarissement des aides extérieures.
Very good. But I know what you've done in Burundi. I can imagine the very good things. But today we want to hear from you, what is missing? How can we do better between health and finance, Honorable Minister? Give me your suggestions how the Ministry of Health can do better in Burundi to collaborate with you.
Merci. Je vais aller directement à votre préoccupation. C'est que le ministère des Finances a pensé à améliorer la collecte des revenus intérieurs pour soutenir les réformes du ministère de la Santé, notamment l'augmentation des revenus de la collecte des revenus en matière du tabac et de l'alcool. Les recettes issues de ces taxes seront orientées dans la finance de la santé. Et le ministère des Finances a aussi augmenté le pourcentage des revenus intérieurs qui était affecté au ministère de la Santé. Et je vous assure que le ministère des Finances envisage aussi faire plus mieux que ce qu'il a déjà fait. Je vous remercie.
Thank you so much. Even after you've increased the budget, they want more. I'm sure they're asking for more, but I'll come to that, Honorable Minister.
Absolutely. Thank you so much. First, I would like to, as well as my colleagues, thanks African Union CDC, AUDA-NEPAD, and AFDB for the putting this important agenda on our common Minister of Finance and Minister of
Observed. All protocol observed.
Second, I came on stage with this, and I would like to congratulate Africa CDC because very important practical book. We have to look at it.
Dr. Kaseya is nodding his head and he's thanked you. Thank you so much.
Finally, and I will switch in French. Il est difficile pour moi de dire au ministre de la Santé ce que j'attends de lui, parce qu'en réalité, nous avons une collaboration qui est extrêmement fluide. Et d'ailleurs, il est dans la salle, il était sur le panel précédent, et je pense que nous sommes certainement peut-être l'un des rares pays pour lequel les deux ministres, Finances et Santé, sont effectivement présents ici pour cet agenda important. Je vous dirai donc les pistes sur lesquelles nous travaillons en ce moment pour permettre de régler la problématique de la restriction des financements dans le secteur de la santé. Premièrement, réduire les coûts de gestion. En République centrafricaine, nous avons vu que sur les financements extérieurs, on arrivait jusqu'à un taux qui oscille entre 35 et 42% de frais de gestion, ce qui est extrêmement important. Nous avons pour cela mis en œuvre une certaine stratégie qui consistait à ce que le ministre des Finances prenne la présidence du CCM sur le Fonds mondial, ce qui est un changement majeur et qui a permis de mettre en œuvre un certain nombre de résolutions, dont la toute dernière, à travers l'Assemblée générale la semaine dernière, a permis d'arrêter ces agences, les contrats avec ces agences, pour pouvoir aller vers des agences d'implémentation. Et c'est le deuxième point qui est important et intéressant, c'est qu'il faut impérativement renforcer la capacité institutionnelle des ministères de la Santé. Et c'est ce que nous sommes en train de faire à travers la mise en place d'une unité de gestion qui implémentera les projets et évidemment à des coûts qui sont beaucoup moins onéreux. Il y a également la question de la gouvernance, parce qu'à partir du moment où nous agissons à travers l'internalisation de l'implémentation de ces projets par les ministères de la Santé, qu'est-ce qui se passe? Nous avons un meilleur contrôle, nous pouvons garantir une meilleure gouvernance et adresser la question de l'efficacité, de l'efficience de la dépense. Autre chose, l'alignement des financements sur le financement des autres secteurs. On a entendu un des panélistes ici parler d'autres secteurs, l'énergie, l'hydraulique, etc., qui sont des secteurs connexes, mais qui sont extrêmement importants parce que lorsqu'on met en œuvre des investissements dans ces secteurs-là, cela nous permet également d'adresser certaines maladies, des maladies d'origine hydrique, par exemple. La question de l'énergie est fondamentale pour permettre aux hôpitaux de fonctionner, etc. Donc, toutes ces mesures-là, eh bien, il faut avoir cette approche globale. Et c'est pour ça que j'apprécie l'approche One Health, mais je dirais, peut-être sans en avoir les aptitudes et l'habilitation, peut-être qu'on pourrait penser une approche One Health Plus qui intégrerait, en plus des ministères d'agriculture, de l'environnement et de la santé, ces autres ministères, énergie, hydraulique, infrastructure, de connectivité, tant routière qu'Internet, pour pouvoir adresser la question de la gouvernance des données. La gouvernance des données est un autre point. Un des gros problèmes que nous avons, ce sont les problèmes statistiques. Pour permettre justement d'avoir un meilleur recul, une meilleure appréciation des situations. Et nous parlons de digitalisation, mais si dans l'état actuel, il est difficile pour nous de collecter des données pour pouvoir informer nos actions et nos décisions en termes de politique publique. Cela est extrêmement difficile et en la matière, nous avons mis en place à travers des réseaux communautaires, etc. Donc un système qui marche très très bien et qui nous permet aujourd'hui de confronter justement les bailleurs et les partenaires sur les statistiques que l'on a dans le secteur de la santé. Enfin, je termine.
As you wrap up?
Yes. Approche business de la santé, c'est une conséquence de ce que le ministre de la Santé disait tantôt sur le plateau lorsqu'il parlait de considérer la santé comme un moteur de croissance. C'est ce que nous faisons en ce moment pour pouvoir justement designer des projets, pour permettre à travers des partenariats publics-privés d'apporter les investissements nécessaires qui permettraient d'améliorer le plateau technique. Et enfin, deux derniers points, capter de la ressource humaine de qualité sur la diaspora, mais pas la diaspora, les seniors, mais la diaspora, les juniors. Pourquoi? Parce qu'ils coûtent moins cher. Et nous avons fait une initiative dans ce sens qui nous a permis de mettre en place un centre d'hémodialyse à Bangui et qui marche très très bien et dont tout le monde est content. Finally, les dépenses fiscales. Les dépenses fiscales représentent un tiers des recettes domestiques en République centrafricaine. En 2026, dans la loi des finances, ce que nous avons fait, c'est que nous avons introduit une réforme majeure qui permet d'exiger le paiement, le décaissement upfront de toutes les dépenses fiscales, de toutes les exonérations à charge, après de pouvoir les régulariser, ce qui permet de limiter massivement la fraude et au final d'avoir des revenus pour permettre de renforcer les secteurs de la santé. Je vous remercie.
Thank you, thank you. First round of questions. The ministers did really well. Give them a big round of applause as we move. I'll start again with you, Madam Minister from Nigeria. I think what I've heard from all of you is stronger collaboration between Ministry of Finance and Ministry of Health. I think that's clear. The second thing I've also heard is innovation of alternative financing does not sit with the Ministry of Finance only. It's a cross-cutting agenda for your whole government and also making the Ministry of Health responsible for PPP models and other ways. I also heard from most of you saying, use tax money properly. However we use it, and however much you can get. And you know, many of the people sitting here are talking about 15% Abuja Declaration. Is there any one of you near 15%? No. Is any one of you below 10%? You see? So they are varied. Now let's go to this issue. This is my second question, and I'm going to start with you. Everyone in Africa is talking about UHC. UHC is a framework of collecting funds and expending funds. In some countries, there is an institution like NHIA, NHIS, NHIF, SHIA, SHA. In your own countries, you have. These institutions are supposed to collect money from health, either through VAT or through something called health tax or sin tax. Some people told us sugar tax. There are many ways. They can even tax oil, mining, industry, whatever. So this is to collect funds, and then they have to have health services being delivered to all. Most of these institutions are housed under the Ministry of Health. In some countries, there is a mix between Ministry of Finance, if you go to Rwanda maybe, and so I want to hear from you. Is the governance structure of what we are doing in Africa for UHC under how we are managing NHIA, NHIS, and all those state corporates, is it adequate, or do you have some kind of a message for us? And I'll give you, again, 1.5 minutes from here. Each one of you will go around.
Is it really 1.5? Because I'm the only one who's stuck to the 2 minutes.
I'm trying so hard.
All right. So, yes, in Nigeria, it's sitting under the Ministry of Health. And I don't think that's an issue per se, simply because of the work that they do. You know, they collecting fees, and then the distribution of it requires more health skills than finance. But what I'll say in terms of the governance structure is ensuring that you have strategic fund management type skills within the NHIA, so that with the funds that you have,
right,
it is, even things like treasury management,
right,
the capital allocation, you need high level of those skills within the institution.
And you have an institution in your country.
Yes.
Do you collaborate with them and your
Not closely enough.
Okay,
no.
so that's a message we've heard from you loud and clear. Honorable Minister from Congo, how is your situation?
So you will be a bit disappointed by my answer, because our institution is actually right under establishment. And it's not under the supervisory of the Ministry of Health, it's under the supervisory of the Ministry of Social Affairs.
Social Affairs,
yes.
Okay.
However, we are of course involved, especially because they need some financing. So we are discussing that. And I will reciprocate the views of the Ministry of from Nigeria in terms of what will be the requirement from the Ministry of Finance in terms of the ability to indeed have real management skills, because those resources needs to be invested. And they need to be managed on a very safe way. And that's where we come in, we step in. It's not for us only to give and to make sure that there is a mechanism that allows for the financing, but we want to make sure that not only the funds are well managed, but we also want the coverage that is proposed to the beneficiary to be up to date. That's what
I'm hearing a common message. Madagascar, your floor.
Yeah, merci beaucoup. Donc, pour le cas de Madagascar, ça rentre dans le cadre de protection sociale pour tous, qui est donc ça rentre dans la protection, le système de protection sociale, et c'est au niveau de la ministère de la Population et des Solidarités. Et donc, nous, au niveau du ministère de l'économie et des finances, nous assistons seulement ces ministères-là, donc, dans l'encadrement des structures en termes de programmation et d'exécution budgétaire pour assurer donc l'efficience des dépenses, parce que on ne peut pas donc plus accepter les gaspillages en termes de dépenses. Donc nous, c'est seulement au niveau, c'est surtout au niveau de l'encadrement donc et de la formation et de l'assistance au niveau de l'exécution budgétaire que nous jouons notre rôle. Merci.
It's again a common message coming up. Honorable Minister Chad, the floor is yours.
Oui, merci beaucoup. Nous, au Tchad également, nous avons un fonds de solidarité qui a été mis en place. Comme vous le savez, nous avons un volet solidarité et affaires humanitaires très important, qui, par solidarité et par engagement, nous avons, malgré la contraction des aides extérieures, nous avons maintenu le cap. Aussi, et ça, ce fonds-là est géré également, comme certains l'ont dit, c'est au niveau des affaires, du ministère des Affaires sociales et des Affaires humanitaires, des actions sociales et des affaires humanitaires. Mais comme je disais tantôt, nous avons des fonds qui sont dédiés et des taxes qui sont dédiées, par exemple, pour la couverture santé universelle, qui a été mise en place pour des problèmes de gestion, de gouvernance et d'efficacité. Ces taxes sont encore logées au niveau du Trésor public et qui sont mises à la disposition de notre système de santé, de couverture de santé universelle. Donc voilà ce que je voudrais dire à ce propos-là pour l'instant. Merci.
Thank you, Honorable Minister. We move to Tanzania. NHIF.
Yeah, NHIF, and of course we also have the fund. So we have an institution and we have the fund.
Yes.
And we have identified sources for the fund. At the moment, in terms of implementation, we've been going gradually. So we started with phase one, basically focusing on really low-income households. The idea is to beef up the fund first, get some investment on it, so that it can also be sustainable. I would like to come back on the Abuja issue, because this, I think, is very, very important. Two key issues to me. One, again, when you look at it, we have to maintain the broader definition for health investment. so that we can look at the 15% or less of it. And secondly, we have 3 sectors that have actually come up with certain percentage allocation for the budget, and that brings a lot of challenges. Health, 15%, agriculture, 10%, education, 20%. Tanzania at the moment invests around $10 billion for railway infrastructure, and simply because we're investing on infrastructure, railway, we have to add $1.5 billion to health, $2 billion to education, $1 billion to agriculture, because we're investing on railway. So for us, I think the emphasis on needs-based rather than formula-based.
Very clear. Thank you so much. Honorable Minister.
Merci. Au niveau du ministère des Finances et de la Santé au Burundi, il y a une réforme qui vient d'être faite où le ministère de la Solidarité a été dissous et les volets qui étaient couverts par la solidarité, une partie a été affectée au ministère de la Justice, une autre au ministère de la Santé, une autre au ministère de la Fonction publique. Alors, c'était dans le cadre d'une volonté introduite par le Premier ministre qui a mis en place des cellules de suivi pour s'assurer de la bonne gouvernance et de la bonne gestion des fonds se trouvant dans le budget général de l'État. Maintenant, les groupes sont mis en place pour assurer une bonne gestion de toutes ces structures.
Thank you. Finally, a minister from CAR.
Oui, merci beaucoup. La même histoire presque que pour le Congo, Madagascar et le Tchad. En République centrafricaine, donc, les ressources dédiées aux actions humanitaires et à la solidarité sont gérées par le ministère de l'Action humanitaire. Mais ce que nous avons fait, c'est que toutes les taxes qui sont collectées et qui sont fléchées sur de l'investissement, notamment en matière du secteur de la santé, sont co-gérées entre le ministère des Finances et le ministère de la Santé. Mais il y a évidemment un travail important de réforme à faire pour permettre justement de dynamiser cela, de mettre en place un fonds de solidarité pour mieux gérer les ressources et surtout les orienter dans des investissements.
Thank you. Isn't this a rare opportunity to have so much knowledge from the ministers of finance talking to us at the healthcare sector? Let's give them a big round of applause. Ladies and gentlemen, I think what's coming out is we have to institutionalize the relationship between health and finance for us to move towards Africa's health security and sovereignty. It is no longer going to be committees and technical working groups in country between health and finance. It's up to us now with Africa CDC Tajuddin to create an institutionalized model. The second thing that I've heard is prevention is cheaper than cure, but it is also better than cure. So as ministries of finance, they are looking forward for us improving our deliverables in the health industry with the funds that are already provided. So they want to see efficiency gains. The third that I've heard from them is innovation, alternative sources of funding should come from the health ecosystem as well, not only waiting for financial instruments or SPVs or donor engagements from the finance and treasury only. Even health can take a leap forward on PPPs that will affect. The fourth I've heard is that the technical capacity of the tax money coming into health, whether it's from oil, sugar, cigarettes, tobacco, payroll contribution, call it what you may in your own countries. What I'm hearing from the Minister of Finance, it's not the collection of the money, it is prudent accountability of that money so that the beneficiaries get it right. And the most important that I heard from many of them is let's look after the vulnerable first. In your own countries, with the money that we collect from whichever mechanism, let's look after the vulnerable and the poor first, because they are in need of social solidarity. And you've used the word all the time about solidarity fund. These are some of the cross-cutting messages, ladies and gentlemen. I know we cannot cover everything. I know if we had the whole day, we would still do a great Q&A, but because of limited time, I think they deserve a great round of applause for what they've done. Thank you. Ladies and gentlemen, you've done very well. Yeah, please come forward.
Thank you, Excellencies, Ministers of Finance, and thank you, Amit, for that great moderation. Excellencies, colleagues, ladies and gentlemen, I would like to crave your distinguished indulgence to switch the agenda around a bit. And in this regard, we will be going to the partners panel. Then after that, we come back to the donors panel. And to moderate this session is no other person than Professor Sheila Tulu, former minister, former regional director, former Chatham House. Professor Sheila, please. And the partners on this panel are the following. SEPI, I saw Richard somewhere. Pandemic Fund, prayer, UNFPA, WHO, Prof, UNAIDS, then the Job Land Institute. Christoph?
Thank you very much. And let me say all protocol observed and just greet my honorable ministers and distinguished participants. I know we stand between you and lunch. So we are going to try by all means to get this panel to be as effective as possible. I've already been introduced, but I'm standing in for Madam Joy Pumapi, who was Minister of Health before me. So between the two of us, we know how to deal with ministers of finance, and I'm just glad I was listening to that panel because we actually got over 15% of the budget. That's why we did miracles. So anyway, now we are here, and we have a panel of really great technical partners. 2, 4, 6, oh wow, okay. It's quite a lot of them, but we'll manage. We'll manage very well. Now, the thing is, I mean, we're talking about advancing Africa's health security and sovereignty, and we're really going to talk about, I mean, I'll just be brief. We're talking about how the partners are going to be working with our countries or have already started that innovation to be able to say, from here, we are moving forth and we will achieve. Now, for us, I'm from, by the way, I'm ambassador, special ambassador of the African Leaders Malaria Alliance. Of course, like Michelle Sidibe, a lot of formers. That shows just how advanced in age I am. Okay, so with that, it's really to say, well, we have the changes in global health financing that have already been well articulated. So with this panel, your task is really to inform us how you have stepped up, to explore the outside of the box country-centered approaches, and also the innovative and blended financing new risk-taking mechanisms, as well as novel forms of collaboration with ministers of finance and ministers of health, the very ones that have already talked, that have already spoken. So I'm hoping that we will be as articulate and as brief and to the point as possible, because they have already said what they are doing and how they are collaborating. So we are going to be seeing what can be done. So with me, it's a great panel. We have WHO, UNFPA, my own UNAIDS, where I was really drilled on the responses. And we have the UNFPA, WHO, the Pandemic Fund, Jup Lange Institute, CEPI, and Gavi. So we will be brief. I know you have a lot to tell us, but try to do a miracle in that you have only 2 minutes each to be able to say what you want to say. And I will ask the honorable ministers to say, I'm a very nice person, I may not stop them, but if you think the 2 minutes is up, clap your hands. That way they'll know, okay, I've said my bit. Thank you very much. So without much ado, I have one question that goes to WHO, UNFPA, and UNAIDS. I'll call in that order. And the question is saying, given the radically changed global health financing landscape, how are the changes that your institution been linked to and supportive of health sector reforms, at country level? So, country-centered, how have they been supportive? I will start with Honorable WHO representative. You have your mics there. Everybody has a mic.
Yeah. Thank you, Madam. Your Excellencies, Honorable Ministers, I salute Ministers of Finance, who just had your panel here. And I think give more money to the Ministers of Health, because you'll have a healthier population, they'll be more productive, and GDP will go up. So, Madam, coming back to your question, and since morning I've been listening here, Africa's sovereignty is not just developmental goal, it's a more political imperative. A continent cannot be sovereign when more than 40% of the health spending in some countries still depends on external financing. Our people deserve systems built in African decisions, not external choices. However, 2025 showed us something powerful. Africa can protect itself and succeed. Last year, WHO, we recorded 114 outbreaks, and we acted. We contained Ebola in the highest speed in DRC, 90 days. We controlled Marburg here in Ethiopia. Mauritius, Seychelles, Cape Verde, eliminated measles and rubella. Seeds country, the 7 seeds country achieved pooled procurement. I was there with Prime Minister Narendra. Prices in these 7 countries of medicine, they've gone down. Mauritius being secretariat, it got 7%, projecting they're going to get 35 million out of it. And we discussed with the minister, you can use the same model for fertilizers, for 85% of the food you're importing. Algeria, I was there with the Prime Minister, reached 82% of pharmaceutical demands, self-sufficient. we are helping them now to go to maturity level 2, eventually 3. Countries eliminated trachoma, coccidiosis, sleeping sickness. We reached 12 million malaria vaccine doses were delivered across half the continent. Our emergency response has never been faster. They are not isolated events. They are proof that African leadership delivers. So despite the financial shock of 2025, all 47 Afro country offices remain fully operational.
Thank you very much. Yeah.
No,
thank you very much. They're clapping for you. So you've done a great job, all of them. Now we have to get to the next person because it's the same question. UNFPA, let's see.
Thank you, Madam Moderator. And this is a very good point that you're asking us, especially building on all the good words and messages that we've learned since the beginning of the morning. I will summarize my 2 minutes in starting by saying progress has been already happening for over than 20, 30 years in Africa. So we're not starting from scratch, especially when it comes to domestic resource allocation and from the commitment the African governments have been putting into strengthening their health systems. So we are not just waking up to the surprise that external ODA is declining, so we African governments need to act. No, actually, it's been ongoing. We've been witnessing significant reduction in maternal mortality rates, significant improvement in family planning use, significant reduction in child mortality rates. So there is a level of celebration despite the gaps that we're going through. So to look at what is happening right now, I feel that there is a good movement. We are not there yet, but there's a good movement by governments investing in health. And if I may speak on reproductive health especially, and I would like to bring you a small example. Over the past 5 years, UNFPA has been partnering with many African countries for the provision of subsidized and donated essential reproductive health medicines, contraceptives, and maternal health medicines. Over the past 3 years, we have been engaging into a business-like relationship with governments, where we are not giving these commodities for free. We are establishing a subsidization mechanism. We're establishing tools like match funding, like looking into how we can consider policies that would increment the domestic allocation of resources. You will be pleasantly surprised if I tell you that over the past 4 years, we've been able to mobilize more than $30 million in domestic resources that are directly used for the procurement of these essential medicines. So there are many innovative financing solutions. They're already underway. And the last word that I would like to say, I think we are in a moment now where we need to prioritize and specify. And as many honorable colleagues mentioned earlier, we need to look into how to improve the efficiency of the system, where the funding goes to those who deserve it, rather than being a general health system that we may miss those who are needed the service.
Thank you very much. Yes, there is progress. There has been progress. It's just that now, I think the past one was a wake-up call to say, let's put more money into where our mouths are. So now let's hear UNAIDS, zero discrimination, zero AIDS-related deaths.
Thank you so much, Sheila. This is really a fantastic opportunity, and we thank Africa CDC, AUDA-NEPAD, and the Africa Development Bank for bringing us together. Just wanted to say that with UNAIDS, we noticed this global financial turbulence, and that's why we started a long time ago, and Michel was here. Under his leadership, we had what we called the Roadmap for Global Solidarity and Shared Responsibility. Part of it, and mainly the big chunk of it, was to work with African governments, member countries, through the AU, to make sure that there is global solidarity through the donor funding, but there is also national responsibilities, and we worked with different governments. Later, we had the catalytic framework, and now we have the roadmap for ending AIDS and other communicable diseases, as well as non-communicable diseases. So through those frameworks, we worked with governments to ensure that we are looking at how governments get more sustainable. Now, our current executive director, when she came in, she realized the big thing that shocked her was the fact that we were looking at 75% of the AIDS response being financed from outside in the African countries. And through this, we came up with what we called my papers are flying away, what we called the sustainability roadmap. Through this sustainability roadmap, we were working with 22 countries, and these 22 countries are already making progress, working with their ministers of finance and ministers of health, working together to see how domestic financing can grow, how we can fund the communities, because we think they're the bedrock of improving our health. And right now we are working with the Africa CDC to see how we can support and strengthen community health workers and give them capacity to be able to operate in their countries. We know even when long donors have gone, these are the communities that always remain there, and they strengthen the health in their countries. So we have been working with this, and we see good results. So far, we see that with regard to HIV financing, we've seen 11 countries already improving on their domestic financing, really carrying forward their responses. We see about 7 countries on the African continent, and we had Zimbabwe this morning, are going to achieve what we call the 95, 95, 95. So we think there is progress.
Thank you. Thank you. We love the 95, 95, 95. And indeed, a la SDG 3.3, Africa will end the epidemics of TB,
Absolutely.
HIV, and malaria. So now, let's go to the other partners. Pandemic Fund, Juplange Institute. Aha. Please share the successes and challenges of innovative financing initiatives that we have supported in Africa. So we want the successes and the challenges. So you have 1 minute for successes, 1 minute for the challenges, or the other way around. Either way, give us hope. Thank you.
Thank you, Madam Moderator, and Honorable Ministers, Excellencies, friends, partners. It's great to be here. I really want to thank Africa CDC, the African Development Bank, and AUDA-NEPAD for this opportunity. The Pandemic Fund, well, you heard it being mentioned earlier today. We are relatively new. We were established in 2022, towards the end of 2022, based on the lessons learned from COVID-19. We're the first multilateral financing mechanism that's exclusively dedicated to working with countries to strengthen their capacities for pandemic prevention, preparedness, and response, and recognition of the fact that investing now, investing in building resilient health systems now, saves
Excuse
lives.
me, conversations are somehow there. Nados? Yeah, thank you.
That investing right now in health systems resilience, in being able to quickly detect and contain health outbreaks from escalating into pandemics, saves lives and saves economic costs for the future. I'm proud to say that in a short period of time, we've already built up a portfolio of $11.5 billion of investments across 128 countries with 67 projects. And 48% of our portfolio is allocated to Africa. With our investments, we are covering now the vast majority of AU member states. We've allocated just yesterday our 3rd round of funding, and with that we have $664 million allocated to countries across Africa. But what's really worth noting here is that thanks to our catalytic model, which incentivizes countries to put their own domestic resources, the $664 million that we've allocated has actually mobilized 3 times as much, $1.8 billion that African governments themselves have invested in this agenda. So, and then on top of that, we're also drawing in co-financing from international partners. So the innovation at the structural level, at the way we operate, is really to use every dollar of grant funding to catalyze additional financing from international partners, but again, very importantly, from the governments themselves, which really is taking us to this journey of sovereignty and self-reliance that we're talking about today. That is baked into our model. Thank you.
Thank you. So you are catalysts in this reaction to ensure sustainable financing. That's really great. Now, the Juplang.
Madam Moderator, I will not speak so much about the Juplang Institute, but from a different function, because as of this year, Director General Dr. Kaseya has appointed me as Special Advisor on health financing and innovative finance in Africa. We already heard several innovative finance instruments, taxes, and so on. I will just focus on one that has also been mentioned, debt swaps, because it combines in an elegant way two issues that need to be addressed. The kind of address the huge debt burden and the huge refinancing of debt that often exceeds investments in health, with the need to increase fiscal space for domestic investments in health. When I was at the Global Fund, I established the debt to health model, and several African countries have participated in that, but we will go beyond that. We will learn from other debt swap models that exist also in other sectors. We will aim to reduce the transaction costs, accelerate the negotiation time, so that countries in Africa can really benefit from that. And my one message is very simple. Any delegations here in the room from Ministries of Health or Ministries of Finance that are interested to be connected to potential creditor countries that are willing to cancel debt on the condition that it will be invested domestically in health can approach myself, my colleague Monica Herder, who's sitting here in the first row, so that we can continue this discussion, and we want to kind of engage with all of you on behalf of Africa CDC to accelerate the use of this promising instrument. Thank you.
Thank you very much. Oh, clap a little bit more for him. Yeah. Thank you very much. That's really great. So the partners have heard you, and they will come over and see how we can plan. Now, my last great people, Sepi and Gavi. What are the enablers of the innovative financing mechanisms, and how can they be strengthened at Ministry of Finance and Ministry of Health level? Okay. That's happy, yes. Enablers of innovative finance mechanisms.
Thank you, Madam Moderator. Let me answer the question by discussing a shared and urgent challenge, which is strengthening our collective health security and specifically African sovereignty in the face of epidemics and pandemics. Africa has consistently demonstrated leadership, scientific excellence, solidarity in responding to infectious disease outbreaks, and CEPI is proud to be your partner in strengthening the continent's health security. But these growing threats demand more coordinated action across health and finance. The last year has seen systemic shifts in the global financing ecosystem, also pivotal initiatives such as the ACRA reset to reposition governance and funding flows within regional and national priorities. In this context, CEPI developed its next 5-year strategy, CEPI 3.0, launched today, through extensive consultations with governments, research institutions, private sector partners, and regional and multilateral organizations. We have aligned our scientific and access goals with regional priorities, including the Africa Health Security and Sovereignty Agenda. Of course, traditional vaccine development economics do not always apply to the pathogens that disproportionately affect the continent, or to epidemic and pandemic preparedness more broadly. To the finance ministers, health budgets alone cannot deliver the scale or investment needed to strengthen regional manufacturing, expand outbreak response capability, or achieve lasting health security, which is why today's convening is so important. Let me conclude just by discussing very briefly a test case that shows how CEPI's unique financing and funding model catalyzes the development and manufacturing of vaccines where the market will not. CEPI is working with a regional coalition of West African governments to design a co-funding strategy to develop and manufacture in West Africa what could be the first Lassa fever vaccine. This shows what is already possible and what more we can build together. We invite all AU member states to join us as leaders, partners, advocates, and importantly, as investors. Together, we can ensure the next emerging threats meet a world that is prepared, protected, and ready to respond.
So how do you plan to make sure that the collaboration between ministers of health and finance happens, because we need to bring them together? What do you do? Yeah.
Ask them very nicely.
Yeah.
No, more seriously, the problem with health budgets is in many countries, effectively, health is still viewed as a cost, not as an investment, despite the fact that I think we all acknowledge that it's an investment. The finance ministers really have to internalize that, and they have to recognize that it is necessary to make investments to prevent the cost of epidemics and pandemics.
Great, thank you very much. That's an answer after my own heart, because as a minister, I used to be told, don't forget that money is being spent there and it's been spent over nothing. It's like, wait till you get sick and you tell me that. So anyway, the last person, Gabi representative, how can, how do enablers strengthen the collaboration between the ministers of finance and the ministers of health? We want them to work together.
Yeah.
It's always nice when they do.
Thank you very much, Madam Moderator, Honourable Ministers. So I work for Gavi, the Vaccine Alliance, and we play a role in vaccinating around half the children born in the world each year against over 20 childhood diseases. But to go to the questions, 3 points I wanted to say. I think one thing at Gavi is we realize the world is changing and we need to change to help deliver the objectives big and bold on the screen behind us. So our CEO is leading a reform process called the Gavi Leap, which is designed to put countries first. We're based in Geneva to think about how we do that much more effectively in countries. The second, the way that we want to do that, we're simplifying things internally, but also externally. So we're revolutionizing the way that we do our grants and we work with countries, not multiple processes, one single process for a long period of 5 years, aligned with national health strategies. And as you say, Minister, bringing different parts of government together and working more than we have done before in the spirit of the Lusaka agenda with other partners, because we know that's an important thing. And then thirdly, Christophe touched on it, just the innovation and blended finance and making every scarce dollar and resource go further. So we've already set up a $1 billion fund to help support African regional vaccine manufacturing, super important for that sovereignty objective behind. And we've also set up a new instrument called the MDB multiplier, where we want to work with the World Bank, Asian Development Bank, African Development Bank behind you and blend our resources better, bringing finance and health ministers into conversations for better outcomes.
Thank you very much. We like the local, strengthening local manufacturing, because we still are dependent on commodities and medicines from outside. That has got to stop. So that's my favorite panel. Please give them a hand. They have been good. And I've been good. I try to keep the time. So give us a hand. But finally, it's really a conclusion to say we've learned a lot. And we know that you promise a lot of innovative ideas and also plans. At ALMA, we believe that we need innovative sustainability plans to ensure that we end malaria. And indeed, we can do that. But let's remember the phrase, one budget, one plan, one budget, and one monitoring and evaluation compartment. So with that, let me say, go forth and collaborate, and we shall succeed. Thank you so much.
Excellencies, I have good news for you. We have Baroness Chapman, the UK Minister for Africa, who's coming. She wants to... Oh, Ministre, c'est une bonne nouvelle pour vous. There is Baroness Chapman who is coming. She heard about the meeting, about all of you who are here, and she has some messages for us. Then, what also we have is another news. This one is not so good news. Our leaders, they have to meet quickly for a critical issue. And maybe they will not be flexible for the afternoon session. This is why we are taking some time now. We can, after the panel, we can go for lunch. Then we wait for Baroness Chapman and also our sister Senait. She's coming. My head of state, they requested to bring the conclusion of this meeting tomorrow to the AU Assembly for them to adopt that. What we'll do, we are drafting, a comprehensive report that will be presented to the AU Assembly tomorrow. But for now, I wanted to inform you about it, as also it came to me. I know they are doing their best. It's a very difficult period for a number of countries, but they are with us and they are supporting us. This is the first one. The second one is most of you will attend the meeting tomorrow morning. I think you know the agenda, but some of you will attend tomorrow at 2 p.m. We have 7 heads of state coming here in the same room to discuss the reform of global health architecture. They will be connected with the Prime Minister of Denmark, Norway, also the President of EU, President Lula, the Prime Minister of Singapore. I think this is a conversation that will take tomorrow at 2 p.m. because tomorrow it won't be like today. Today there are so many other issues. I'm so sorry for that. I will keep you a little bit. After the panel, we'll go for lunch, then we'll wait for Baroness Chapman if you are in agreement. Because the UK is doing a lot for us. Don't forget that they provided 1 billion to Global Fund, around 600 million to Gavi, and a lot of bilateral programs with each of us. May I have your pardon for that? And you accept? Thank you so much.
Thank you, DG, for the announcement. Excellencies, colleagues, ladies and gentlemen, so we move to the next panel, which is a donors panel. And to moderate this particular session is Richard Muigo, Director, Strategic Engagement, External Relations, Partnership, Gavi. Panelists are Germany, hope they're in the room, Norway, UK, United States of America, Gates Foundation, Germany, Norway, UK, US, Gates Foundation,
yes, please. Yeah.
All right. Thank you, Dr. Taj. And I think there are a couple of panelists that were announced, but I'm sure they're going to join us a bit late. This is the last panel before the lunch, but I can promise you this will be a very interesting one. I think we're going to have a great discussion with our team. And Dr. Kaseya, if you allow me, I think I would like to just correct one small thing on the UK contribution to Gavi. Actually, UK was even more generous than what was announced. I think it was more than 1.2 billion. So it's not 600. So thank you, UK, and your commitment to vaccine. To this last session is going really to kind of go back to some of the conversation we have had so far since this morning. It was quite inspiring to hear not only the theoretical parts that was presented this morning. I think Ngashi did a very great presentation on the health financing ecosystem in the region. We heard quite a very inspiring conversation with ministers, both health and finance. And it was interesting to hear the perspective from donors as well, and our partners just before us. But this last session is about the donors, and I'm sure many of our colleagues sitting here, they may not want to use that term donor because they are more than donors. I think they are real partners on health sovereignty on this region. So I think since this morning we are talking and discussing on how we can advance Africa health security and sovereignty. I would like also to recall conversation that has taken place around the Lusaka Agenda principles and declaration, which all call for a really shift in the way we are not only planning but delivering health services in the different countries. In this morning presentation, Ngashi talked about the contribution of the development assistance for health, which has, in the last 2 decades, contributed a lot. But more recent past, we are seeing a decline on that. And I would like to take really this opportunity for this panel to have a sort of honest conversation with our partners here on how they are looking at the redesign of all of these processes to help countries not only to align behind their own priorities, to align around their systems so that we can deliver better health and security for our people on this continent. So since we have time, 3 panelists, I think I will definitely try to use one question for each panelist. Maybe let me start by my sister Cathy Fall from the Gate Foundation. Cathy, I think you have transitioned recently to Gate Foundation. It's not a secret with your rich experience in the Global Fund over the couple of years. So can you please tell us how the Gate Foundation evolving its financing and partnership model to act as a catalytic support in the region?
Thank you very much, Richard, and good afternoon, everyone. I think now it's afternoon, and we're standing between you and your lunch, so we'll ask actually for your kindness so we can go through this panel. It's not going to be easy for Richard, for you to keep attention, but yes, I have transitioned from GF to GF, interestingly, if we look at acronyms. But the crust of the work is still the same. It's really about the people that we serve. It's about their health, it's about their livelihoods, it's about their well-being, and that is why we are all in this room today. Thinking through health financing, and you said it, Ngashi did actually a very good presentation this morning, talking about the poly-crisis that countries, governments are facing, but also the opportunities. And we know that health financing is at an inflection point. But we should never waste a crisis. I think in a crisis actually comes out great ideas. And while the Gates Foundation is not there to replace aid, Gates Foundation is there to play a very catalytic role. And I think that many countries that have benefited from Gates Foundation financing have seen the power of catalytic investments. And not only catalytic, but also risk-tolerant capital that have supported countries in building systems that can be sustained. And I think that what we aim at is really leaving things that outdo or outlive our time. You've heard Bill Gates last year announce that actually this organization will be sunsetting in 20 years. I mean, what better statement? This means that as of this year, we have 19 years to demonstrate results and impact. So what do we do? I think that 3 comparative advantages for the Gates Foundation. The first one is that we invest in innovations in tools, be it drugs, diagnostics, data platforms, and all of that to reduce disease burden. All of that to make prevention, treatment, and care affordable. That's the first one. The second one is that we invest also in innovation in service delivery. And we have a number of countries where we have invested also on that front, be it in digital system. And we've heard, our Minister for Rwanda this morning talking about digital systems, but also AI and technology in response to the various challenges that our countries are facing when it comes to health. Performance-based approaches as well. And last but not least, new operating models that improve efficiency, but also improve transparency. We are hearing about these delivery units, we're hearing about the health transformation units. We are in it with the various governments that we work with. The third element is that we actually support the bearers of public goods. We really work very closely or support or partner with the Gavis, with the Global Fund. We champion also organizations like UNFPA. It matters to us because of the mission that they are carrying. And in addition to that, on the continent, and I want to come back to the continent, which for me as an African is what has warranted my shift also from the Global Fund to the Gates Foundation, because there was a position on the continent, not because of the mission, but because of a position on the continent. We also partner with African institutions. We partner not only with Africa Union, but also with Africa CDC, with AUDA-NEPAD, and the African Medicines Agency. Very critical as well when we talk about regulatory frameworks and we talk about actually sovereignty. So these instruments are ways to strengthen the continental architecture that carries sustainability, that carries security, and that carries sovereignty. So we are evolving our model because I think that as the world is changing, we can't just expect that others are evolving and we are not evolving. So we are also evolving our model. And we're doing much more work to de-risk at very early stages innovations. And we're doing that with Gavi, to shape markets and lower prices. We're also doing that with Global Fund and UNFPA, strengthening pool procurement, but also working on the resilience of supply chains, and much more now also breaching now to the continent and trying to emulate those efforts. We have catalytic investments with institutions like the Institut Pasteur on vaccine manufacturing. And I think that development finance for vaccine manufacturing is the future for Africa as well. So very important as well for the Gates Foundation. And we are I was very pleased to hear the Minister of Finance of Nigeria this morning, because we are being also thoughtful partners to country-led reforms. When you take Nigeria, not only on the financing front, but particularly on the health front, we invest actually in the basic healthcare provision fund. And that is to strengthen primary healthcare. That is actually to also push not only for results, but for more transparency, more visibility, more accountability. And thereby, when you improve your budget execution and you improve visibility and transparency, you give selling points to Ministry of Finance when they have to make trade-off decisions, because you are actually arming them with elements that no one can come and say, oh, health is actually not absorbing. So all of this really to say how important it is to stay on these agendas, that matter for the people that we serve. That's the reason why we are all here, that we are here the next 4 days in Addis, and I trust that we will continue journeying together.
Excellent, excellent. Thank you very much. I may come back to your statement on how the Gate Foundation is working to put itself out of business in 20 years. Quite an interesting concept. At Gavi, I think my colleague mentioned the Gavi Leap, and I will come back to that. Let me move to the UK. I think the UK has been a very important partner for the African region, but also on the agenda on advancing health security and sovereignty on this continent. And we are looking forward, indeed, to welcoming Baroness Chapman in the afternoon. But let me ask you, in many African countries, we know that countries are dealing with different processes, different systems, reporting, fiduciary requirements, sometimes imposed by partners, donors, global health institutions. And I would like to know what are the specific steps that the UK is taking or exploring to take actually to reduce this fragmentation. We heard a lot about fragmentation since this morning, but also the transaction costs linked to that.
Thank you. And thank you all so much, Honourable Your Excellency Dr. Kaseya and Honourable Ministers, for the opportunity to be here. I stand not only between you and your lunch, but you and my Minister, who will say far more eloquently than I can how important this gathering is to us. It is in fact the first time the UK has been invited to participate in the AU, and we feel that is a very great honour. And it's a great honour for us because we are deeply committed to indeed advancing Africa's health, security and sovereignty. And I'm really delighted by the question that you have asked, because for us this issue of aid effectiveness is fundamental to how the UK has always been committed to giving our development assistance. And you started out by describing us as a donor panel. In fact, within FCDO, which is the Foreign Commonwealth and Development Office, we've now brought development in alongside all of our diplomacy issues, because we know that health diplomacy, the soft power of engaging in the health sector, is as important as all the other diplomacy we do. And as I think many said, health is wealth, and we know how important this is to the continent. Within FCDO, we now talk not of ourselves as donors, rather we have what we call modern development principles, and we are all asked to consider these. And the first shift we're asked to go through within FCDO is to go from being a donor to being a strategic investor. We are going from supporting service delivery to strengthening systems, something that those of you who know DFID will know we were always very committed to, but this is front and center of our support. From giving grants to supporting with expertise, so that as donors exit, as countries become more sustainable, they have their internal skills and are not reliant on external support, either technically or financially. And finally, going from international delivery to localization and national ownership. And this really isn't a new thing for us in the UK. Michel Sidibe alluded to the 3 1s earlier, and I recall 20 years ago sitting with UNAIDS and Norway as we crafted the 3 1s, which have now become, you remember that too, Katy, that have now become the Lusaka agenda. And one of the things that I feel most excited about with the Lusaka agenda is it does have a genuine African ownership. And I think we're all very pleased to know that the President of Ghana will be with us here in Addis, and the Accra Reset is now taking all of the ambitions we have around the 3 1s and the Lusaka agenda to the next level. I was really shocked by that excellent presentation from Dr. Ngashi earlier, by some of the statistics that 20 to 40% of health assistance is wasted because of donor behavior. I think I was really shocked to hear that external financing is reducing, and yet the number of donors is doubling, and the number of donor implementers is doubling. For us, those are not acceptable ways forward. We are really deeply committed to working alongside countries behind your national leadership. We have the pleasure of doing that in a number of countries. We have the pleasure of supporting Africa CDC because we believe in the continent's leadership. And I belong to a team now called the Global Fund Accelerator, which is not just about the Global Fund. It's about the Global Fund, it's about Gavi, it's about the Global Financing Facility, and how we can work both at the Secretariat, Headquarter and Board levels to support those instruments to work better together, and how we can also work in countries to support them to get the most possible benefit out of those funding flows.
Oh, very, very good, excellent point. And I like the way you are framing this UK support, not necessarily as a donor, but really as a development partner. And this is why I started by saying, I'm not sure that this is not only a donor panel, it's more than that. Let me come back to you, Frode. I think Norway has played a critical role in the discussion around the reshaping of global health architecture, the discussion around Lusaka agenda, etc. So, as we've heard from DG Kaseya, there will be even more conversation around the global health architecture during this conference. And we know that this reform is really critical to catalyze the implementation of the African health security and the Lusaka agenda. So how do you see the many ongoing conversation going on the global health architecture reform? And what the balance should we be seeking between global architecture reforms and the country-led reforms required to realize the Lusaka agenda?
Thank you so much for the invitation and all protocols observed. I think that's a very crucial question, a very pertinent question. So we've also been very active in setting up the global funds and Gavi and all these institutions that have been very instrumental in helping also reduce child mortality for the last 20, 25 years. And we have to then be active now in restructuring, I think, these systems. I think the current global health architecture has largely been designed to respond to the Millennium Development Goals. And these priorities remain still critical, but the world has changed. Partners across both the global north and south are clear that we now need a more holistic approach to deliver universal health coverage and to address the shifting disease burdens, to strengthen preparedness and ensure financial protection. And Norway really supports the coherent reform of the global health architecture anchored in the Lusaka agenda and aligned with the Accra reset as a political, you can say, umbrella for the whole thing, and also the Sevilla platform of action for financing for development. And the objective is integrated, resilient health systems that deliver results at country level, also including WHO at the center of a norm-setting function and also a coordinating functions and country support. And we think equity is fundamental, with still billions lacking essential health services and facing catastrophic out-of-pocket payments, as we have talked about today. And we need global efforts. They must prioritize, I think, first low-income and conflict-affected countries, and to start where the needs are the greatest. And we support, of course, the AU principle of one plan, one budget, one evaluation system, and also a health reform that has to follow a financial reform, as been talked about today. And to be serious about African sovereignty, I think we need from the global north to accepting being led from the global south. And I think that will be the litmus test also in the boards of these organizations and in the way we are setting up the future architecture. And to, instead of being donors, engaging in what we call equal, I think, respectful partnerships, as it was also formulated in Africa CDC. Thank you.
No, very much. Thank you very much. Being engaged as equal and in a more respectful manner. Maybe just to conclude, I know we don't have much time. I would like to kindly ask the three of you maybe to reflect in 1 minute, 1.5 minutes, looking forward. What will be the 1-2 things that you believe your organization, your country can do really to contribute to these goal of African health security and sovereignty and the promise that come with the Lusaka agenda? May I start with you, Kathy?
Thank you very much, Richard. I think I'll start where our colleague from Norway ended. For us, the first thing, and we've heard it loud and clear actually from senior leadership at the Gates Foundation, is to listen. Listen to African countries and meet them where they want to go. Because I think that we have 3 mission goals at the foundation that speak to any of the African countries that are actually in this room today. The first mission goal is about ending maternal and child mortality. Our 3 comparative advantages are about innovation in tools, innovation in delivery, but also making sure that global public goods are continuously available. What we will do is actually really journey with countries on the how. How will we make that happen and co-create so that it happens and serves impact and results, and we have actually a narrative of success in 19 years.
Thank you very much. The how, joining the country on how to deliver things. Thank you so much, Kathy. Let's move to my friend from the UK. Yeah.
It's slightly difficult to follow Katie because I just wanted to say what she said. I think that, you know, we are really very...
Which is good.
Which is great. I think we're very aligned with those perspectives, listening, respecting, following your lead. And I think as we move forward with our investments in your future, it's about investing in the systems that you know in Africa you need. We also are proud to support the Institut Pasteur, to support the local and regional manufacturing agenda. And I think it is very important that all of us take a great deal of care to follow those one budgets, one plans, one monitoring framework, and to make sure that we're coherent, that we're not saying things at the global boards which do not match with what we are experiencing in the privilege of living in your countries, as many of us do. So I think we need to do more and do better around that. And we're doing it not just because external finance is changing, but because it is the respectful, the right thing to do, to anything within our power to support your sovereignty, so that as donors exit, there are the capacities and the systems in place.
Thank you very much. Then finally.
Thank you. I think I'll have 2 points. The first one is actually what we did during the replenishment meeting in June for Gavi. We announced the amount for Gavi and the Global Fund in the same meeting as a signal that they need to work closer together, and we need to find ways of having a better collaboration also of the big funding institutions in this field of global health. The second point is that we have to take now the Lusaka agenda from the agenda into deliverables, into key performance indicators, and into Lusaka results. And as you probably know, all of you, there are many initiatives now on global health reform. We need to find a good landing space for them and where they can utilize the strengths of the different initiatives. And we need the WHO as a coordinating partner in this. And we are working together with South Africa and Africa CDC, Spain and France and other partners also and Ghana included there, to find also a discussion room for this within the African context, which we will further develop tomorrow, where there will also be a greeting from our Minister of Health, who should have been here. And so I'll say, pass my greetings from Dr. Jean-Christian Vestre. He had to take over the role as being the Prime Minister for some days. That's why he couldn't come here. He regrets this very much, but he sends a video message for tomorrow.
All right, thank you. So I think I told you the best was coming at the end, and you all see how this was a fantastic session. So can you please give a round of applause to our 3 panelists? So I think this brings us to the end. I would like to pass the microphone back to Dr. Taj. But before that, maybe for our panelists, we can have a last picture.
Thank you, Richard, and thanks to our donors for that very great session. So, it's time for us to break for lunch before we come back for the Minister of Development from UK. But before we break for lunch, just some very few announcements from His Excellency Dr. John Kaseya, so that we clearly have what is it in terms of our next steps.
You know, when we say head of state they will not come, they will start to challenge me. A president is coming. The president of Comoros is coming to represent others. This is the first one. They said we cannot leave our health leaders like that. He wants to be the person who will collect all message to bring to head of state. He was mandated by all other head of state. The second one will have a panel session with Baroness Chapman. Some ministers and partners will sit and discuss with her. She wants this kind of dialogue with our colleagues. And it's an opportunity for us to ask many questions. The third one will have also a message from my sister Sanya. She recorded a message, and but before landing there, because we need to be well prepared, we know the lunch is ready. I don't want some people to say the DG doesn't want us to eat because himself he wants to lose some weight. No, it's just because we want to get opportunity to have some feedback. But what I want to suggest, can I suggest to go for lunch, to break for lunch? We eat, then we come back here because others they are also joining us. Is it fine like that? Okay. Then let us break for lunch. It's ready, and then we will come back when also the president and other people are here. Thank you so much.
What is?
Put a mic.